Last but not the least, we value your feedback. Please scan the QR code displayed on the screens after each session or provide at your table. And during question and answer sessions, try to keep the questions brief to allow maximum participation. Thank you. Suprabhat, Vadakkam, Inakwa for all the West African delegates sitting here, Subba Osesak for the Sri Lankans, Asubuhi Jema for Tanzania, and a very good morning to everyone. It's a pleasure to welcome you all to the final day of the first International Symposium for Tribal Health 2025. I hope you're feeling energized and excited for the ahead. We have had two incredibly impactful days so far, and today promises to be just as engaging and insightful. Yesterday, day 2, we began with an exemplary plenary session which set the tone for rest of the day. It was followed by insightful scientific sessions and a dynamic panel discussion which encouraged thoughtful debates on critical issues. I think we all agree that this symposium has been a great platform for learning, collaborations, and networking. Today, as we move into the final day, we will continue with a keynote lecture, followed by some scientific sessions, and another stimulating panel discussion for the day. I encourage each and all of you to make the most of today's session and interactions. Let's continue to learn, share, and build towards a brighter future. Before I invite the keynote speaker for today's session, I would like to call upon the chairpersons, Dr. Jay Deshmukh, Distinguished Senior Physician and Director, Sunflower Hospital, Nagpur, and Dr. Shrikant Mukewar, Distinguished Senior Physician and Gastroenterologist, Director, Midas Hospital, Nagpur. Please help me welcome the chairpersons on the stage. It's my honor and pride to welcome the keynote address speaker for today's session. He's none other than Dr. Prashant Joshi, Executive Director and CEO, All India Institute of Medical Sciences, Nagpur, Maharashtra, India. Sir is a medical teacher, a consultant physician, administrator. Sir holds more than 200 research publications in top prestigious journals like JAMA, BMJ, WHO Bulletin, Lancet, and many more. Sir has been featured in top 2% most influential scientists in 2023 Stanford University list. Dr. Prashant Joshi has been awarded with COVID Warrior Award by Honorable Governor of Maharashtra and by IMA. He is a WHO advisor, consultant to Ministry of Health and Family Welfare, consultant to Government of India and ID's SP. Principal investigator in multiple funded research projects held by WHO ICMR. We invite Sir to please share his knowledge.
Namaskar and good morning to all of you on this Sunday morning, and good to see so many people. We respected dignitaries on the dais and the chairpersons, my teachers, Dr. Shrikant Mukhewar, the first gastroenterologist of Nagpur, who is the director of Midas multi-specialty hospital, and Dr. Jay Deshmukh, a very senior and renowned and very efficient and a very proficient clinician. Both of them are very senior, respected clinicians here, and very happy that they have come and to chair my session here. So what I bring greetings from this All India Institute of Medical Sciences, and what I will be talking about is unveiling the hidden burden, addressing health disparities in tribals through empowerment and policy. We all know of a lot of health disparities which already exist. I'll briefly deal with them first initially, and then will emphasize on certain unknown hidden health disparities, and then would concentrate on what aims Nagpur is doing in this area. As we all know, tribal population constitutes about 8.6% of the total population. More than 10 crore tribals are present in India. But this is a very diverse population. There are more than 700 unique communities, more than 75 tribal groups identified, categorized as particularly vulnerable tribal groups. They have their own unique culture, customs, rituals, beliefs, traditions, own way of life, which should be respected. They speak nearly all of them, if you say they're more than 300 languages, so it's not a homogeneous group. Many of them, majority of them live in remote, inaccessible, hilly areas, forest areas, which are very difficult to access and to reach. And they play a very crucial role in conservation of the nature. Now, these are very well-known health disparities. One of the good things is that the sex ratio is much better than what in non-tribals. We know that there is very limited infrastructure, their health infrastructure. Their life expectancy is 4 to 5 less than non-tribals. And of all the malaria deaths, 50%, though they constitute only 8.6% of the total population, 50% of them of malarial deaths occur in tribal population, which clearly means we need to concentrate on these aspects if we really want to achieve the goal of the Government of India's goal of eliminating malaria by 2027. TB is quite prevalent, 6 to 7 times more than non-tribals. And if by 2025, which is difficult now, we need to concentrate on tribal population very much. Institutional deliveries are at their lowest, and a tribal mother is twice likely to die at childbirth than a non-tribal mother. Infant mortality rates are higher, under 5 mortality is high, underweight is common, and malnutrition is seen in 75% of tribal and lactating women. 65% of tribal women have anemia. Now, these are some figures which are there. This again shows the reported illness in tribal infections being more common. Now, this is an old slide in 2014. The data is now changing, and non-communicable diseases comparatively less because of their healthy lifestyle. Similarly, undernutrition is common. The healthcare workers and the doctors, the paramedical workers are very less in tribal population areas. Similarly, if you see here, the, the International Day for World Indigenous People is observed on 9th of August. And postings of doctors and health workers, which are very less in tribal areas, need to be made lucrative by financial and non-monetary incentives. Only 15% of tribal women receives complete antenatal care during pregnancy. Similarly, nearly 1.5 lakh tribals actually die below the age of 5 years, which is totally preventable. But these are known facts. We know all these things. They are socio-economically they are underserved, and their access to healthcare is less. But what is the hidden burden in tribal population? This is not working properly. Okay, so I'll start with this ICR study, which is being conducted by the Community Medicine Department at AIIMS Nagpur, which has again a very startling revelations. And this project is funded by ICMR. More than about 5,000 people have been screened. The main purpose is to do NCD screening, and not only NCD screening, but risk factor screening is very important in the Ramtek area, in the block area. And the main purpose is to improve the utilization of public health services we existent, because they are not being utilized though they exist. And capacity building of health staff, telemedicine services, village sanitation, nutrition improvement, and making the essential drugs available are some of the other aspects. Very importantly, 1,000 cases of hypertension have been detected of the 5,000 people screened. But about only 5% of them knew that they had hypertension, because it remains undetected, untreated, and uncontrolled. Similarly, diabetes, because these are basically silent killers, and they remain undetected, untreated, and uncontrolled. And these are screening camps, again, which are held at Ramtek. And health awareness camps which have been taken, not only of the population, of the tribal people, but also the existing, the doctors there and the paramedical staff. Awareness about all these non-communicable disease and health education has been conducted under the program. And 29% patients in tribal area had hypertension, 12% had diabetes, and this is more than 30 years population. These are again camps which have been held by the Department of Community Medicine there. And these are again our results from the INDIAB study in which we participated, our largest nationally representative study being conducted, and a state-sponsored study, which again showed that more than 75% of the population, the diabetes remains undetected, and therefore awareness programs are very important to to increase the awareness not only of diabetes, but also of hypertension. I'll use this. I think this is better. I don't know why they did this. So prevalence of hypertension again remains undetected, untreated, and uncontrolled. Pointed, I want to make the slides forward. This is not to do it here. Okay. So this is another very important study which has been conducted and reported in 2022, not by us, a community-based survey with more than 50% population in 5 tribal districts using verbal autopsy tool to know what are the causes of death. And very surprising results. We thought that cardiovascular diseases, communicable diseases are less common in tribal population because of their healthy lifestyles, and the very startling results published in the Indian Journal of Medical Research of ICMR, which shows that nearly 66% deaths were occurred because of non-communicable diseases. These are very startling figures. Very interesting facts about these deaths in the tribal population is that 70% of the deaths occurred at home. 1/4 of the deceased did not seek any treatment for the illness, which is again very dismal. So the health seeking and behavior needs to be altered, very important. Hypertension and remained undetected, untreated. In this population, 42% were tobacco smokers. 37 used smokeless tobacco. In fact, the tribal study which was conducted by us in the community medicine of AIMS actually showed 74% use of tobacco, and the use of smokeless tobacco was very high, and patients, many of the patients had precancerous oral lesions like submucous fibrosis and oral cancers. The key risk factors, the use of alcohol, very high. Local mahua, it is traditionally acceptable to use mahua during festivals, and in fact, it is not considered a taboo. Smoking also is not a taboo. Using tobacco daily, smokeless is a way of life. Very high rates of alcohol use and smoking. More than half of males consumed alcohol, and a quarter of them actually had a hazardous use of alcohol. Very young age at which alcohol intake and tobacco was started. That is very disturbing because then they get these cancers very commonly. This is again because culturally this is very well accepted and in that community, in that tribal areas. And it is easily available, and wider cultural acceptability in society are responsible for use of these substances. Now, there are certain diseases which are hidden, we don't know about them, like the human trypanosomiasis, the first case which we described in the tribal area, from a person who presented with high-grade fever and altered consciousness, was admitted with us for more than 5 months. And with the peripheral smear actually was studied with these motile trypanosomes, which was associated with bouts of febrile bouts and disappeared when the patient was afebrile. And this was confirmed by molecular studies. And then we did a serosurveillance study in there, which found that there are very high prevalence of seroprevalence of nearly 20%, indicating high rates of infection but not disease. And this was reported subsequently. So high burden of diseases, hypertension, 1 in 4 tribal person has got hypertension, and of which only 5% of men and 9% of women actually knew that they had hypertension. Then malaria, as I've already mentioned, 42% of tribal children were underweight, 1.5 times more than non-tribal population. Now, what is AIMS doing in shaping the tribal health? We know hemoglobinopathies like sickle cell is very common in tribal population. We have already established the Center for Excellence very recently on 3rd of August. And very recently, 2 months back, we have been awarded the Center of Competence by the Ministry of Health and Tribal Welfare. Only medical college in Maharashtra to be awarded the Center of Competence by the Ministry of Health and Ministry of Tribal Affairs. In addition to that, free consultations or teleconsultation services, e-Sanjeevani, using mobile medical units, health camps, and capacity building and research are some ways in which we are trying to shape the tribal health. Research, as I've said, should be action-oriented, context-specific, resource-sensitive. Now, there are a lot of tribal areas which have different traditions, therefore area-specific, tribe-specific, tribe-centric. It should be need-based, focusing on the health needs and well-being of the locals, and addresses the health disparities in this diverse, marginalized population. And in aligning with the National Health Mission's goal of eliminating sickle cell disease by 2047, the Center of Excellence was inaugurated by Honorary Gadkariji on 3rd of August, and we were approved by our Center for Competence by the Ministry of Tribal Affairs, and we have received at this point of time the initial grant of 1.14 crores. We have done a lot of training for sickle cell disease, for training of trainers coming from various districts, and workshops have been conducted. In addition to community outreach for sickle cell awareness, nearly 2,000 people have been addressed. Telemedicine services for sickle cell patient, a unique facility which has been offered by AIIMS Nagpur for consulting OPD from home. And you can see here, once we have established the Center of Excellence, we look at the graph over here. After 2024, the number of patients who were free investigations and treatment, hip transplantation, other surgeries have been done. The number of patients treated in OPD, sickle cell patients, and in the IPD rose exponentially after in the last few months. In addition to that, in sickle cell disease, we are providing free prenatal diagnosis and testing, and chorionic villi sampling. This has been done in about 80 patients, pregnant females. Amniocentesis is being done, and molecular studies, next generation sequencing and Sanger has been established molecular lab in AIIMS Nagpur, and for molecular studies, for genetic studies in this condition. This advanced, fully equipped bone marrow transplant unit has been established, again inaugurated by Honorary Gadkariji, and advanced treatment facilities are available at AIIMS Nagpur for like erythrocytophoresis, for patient was successfully treated of who had persistent hyperacute non-responsive vaso-occlusive crisis in sickle cell disease patient by means of RBC apheresis and exchange. So we have external experts here who have Dr. Dipti Jain, Dr. Khaparde, and Dr. Shrikande Madam. All of them, we have a meeting by HPLC on a dried blood spot. In addition to that, molecular testing is being done, HLA typing and for bone marrow transplant and matching has been done. So this is about sickle cell. In addition to that, a very important telemedicine initiative has been initiated by the Department of Neonatology under Dr. Banai at Dharani, Melghat, with the help of an NGO called PATH, where we know Dharani is a very tribal area and very high mortality rates. And with this impact of telemedicine, training the nurses, training the paramedical staff, and their visits to us here, in addition to regular daily basis telemedicine consultation being done by the new neurology department, has resulted in a significant impact of 50% reduction in referrals from Dharani to Amravati, and has significant drop in sepsis cases and significant drop in mortality also. So that is one. And another one very important initiative which has been done is telemedicine consultation and outreach activities have been done. And another telemedicine programs and outreach activities being created at the Gadchorali, where actually we have done the gap analysis at the SNCU there, and we will be starting that center there also. So Gadchorali, as we know, is an aspirational district of our Honorable Chief Minister, and we want to reach the poorest of the poor there and provide our expertise to these people to uplift their health. And for this, we have the AIMS Nidan Kendra has been established. A DBT-sponsored project for common genetic and metabolic disorders is, we have received a grant of 4 crores, 27 lakhs with the Department of Anatomy. And antenatal screening and prenatal diagnosis of sickle cell disease is going to be done. In addition to that, newborn screening for hemoglobinopathies and metabolic disorders such as congenital hypothyroidism, congenital adrenal hyperplasia, and other metabolic disorders is going to be done under the NAM. So this will be a very important initiative, and this is restricted only to people coming from Gadchiroli area. Similarly, the Ayush ICMR, we have received number of grants. Collaboration is being done, especially for detection of oral cancers, pre-cancerous conditions is being done, and we are collaborating with Ayush, and we have received an ICMR grant for that. And there are, in addition to these programs which are being run at AIMS Nagpur, there are a number of programs which are being run by the government, tribal welfare programs and schemes like the National Free Drug Services and National Free Diagnostic Services. And they're very good Eklavya models, residential schools for health education and ashram schools, which provide education to tribal population school, and is very important. Ashwasan campaign, which has been started by Ministry of Health and Family Welfare along with the Ministry of Tribal Affairs, and for being a TB-free India, tribes for a TB-free India, going to the remotest area. So improving the healthcare infrastructure, strengthening human resources, promoting health education awareness, culturally sensitive healthcare, strengthening community participation, enhancing outreach and mobile health, research and government policies are some of the potential solutions for the upliftment of health in the tribal population. And this would be my last slide. In order to improve the India's tribal health, we need to empower the community through health education awareness, and we need to, there are a lot of problems of communicable diseases, but also the emerging problem of non-communicable diseases like hypertension, which diabetes and heart diseases, which remain undetected, untreated, and uncontrolled. And cancers, where the late detection is very common. Patients come in advanced stage where nothing much can be done. We need to overcome the problems of availability, affordability, acceptability, and accessibility, and formulate and implement strategies which are lifestyle linked, population based, resource sensitive, and it needs to be context specific, tribe specific, and area specific. And therefore, one policy for all the tribal areas would not be adequate. This needs to be done by an energetic coalition of health professionals involving government doctors, non-government organizations, and very important, we need to rope in traditional healers, ASHA workers, Arogya Mitra, Ayush workers, and integrate them with modern medicine, because the problems of acceptability of modern medicine with the tribal population, that is a very important barrier for health, and improve the health seeking behavior of tribals is very important. And this should be accompanied by an enlightened policy and changing the environment diet, which should be done. And this existing policy needs to be revisited, re-improved by the government of India, the Ministry of Health and Tribal Affairs. So thank you everyone for a patient hearing. My time is up.
Thank you so much, sir, for such an enlightening keynote address. Your presentation really made us all aware about the exemplary work being done by AIMS Nagpur and India for the indigenous tribes. So please have a seat. I would request our esteemed chairperson to share their words of wisdom.
Well, thank you very much. And it was a very excellent presentation by Dr. Zugshi. What was most impressive was the contribution of AIMS Nagpur to tribal healthcare. And being a Nagpurian myself, I thought, well, I'm very proud of what AIMS Nagpur is doing for tribal healthcare, particularly in Gadchiroli area and so on. He has very elaborately told us that right from infant mortality, then maternal mortality, then sickle cell disease, non-communicable diseases and all that, They are doing a wonderful work, and they are also visiting the remote areas in tribal areas like Melghat and Gadchiroli to find out people who are suffering from all these health issues, and they are trying to improve their tribal health. That on one side. My personal viewpoint is that besides what is being done for all these things, we should also exploit the tribal medicine. Tribal people must have had some medicines which might be used for snake bite or some arrow injuries, or carrying out deliveries in their hutments. They must be having some herbal antiseptics. You know how quinine came, you know how reserpine came. So there has to be something in the tribal medicine also. So I hope that the authorities over here would also give some importance to tribal health medicine. So tribal medicine could be anything, and not all tribal medicines would be bad or they would have side effects. But it's our duty or your duty or all our duties that to exploit those tribal medicines and find out which would be important. Who knows? There could be something for sickle cell, there could be something for collagen vascular disease, there could be some antibiotics, which are herbal antibiotics, which don't have any side effects. There could be something for scorpion bite. So I think we have to move in that direction. For that, I would request Madam Kanitkar and Dr. Joshi and others and other health authorities who have come over here to try to exploit this tribal medicine at the basic level and go to the top and find best this because you are now having good access to the tribal people. So along with that, there could be some tribal doctors also, and try to see what is good for the urban population also. With these few words, thank you very much.
Well, at the outset, let me express my sincere thanks and gratitude to MUHS, AIMS, and Dr. Sanjay Chaudhary for asking us to chair this very prestigious session. I am really glad that this topic has been taken, the first international conference on tribal health, up till now not recognized, having 36% of the tribal population in India. I think it's a great initiative to have discuss on this topic in this particular conference. It was disheartening to know we've all had a concept that infections are more common, but it is disheartening to know that even metabolic associated disorders are also on the rise in tribal population. And we really admire the work which has been done by AIMS Nagpur, but I would suggest that you involve the private doctors also in this initiative. We are more than ready to help you because it's a huge task and the private doctors also should be involved in it. We had a small experience of testing hepatitis B in 3,000 rural population, and surprisingly, there was no positive result. We've been doing upper GI endoscopies in the rural areas as a prerogative of our medical foundation, but we have yet to analyze the results of how their diseases are different from this thing, from the urban population. And with this, I wish all the best and thank you so much.
Thank you so much. Thank you, sir, for your valuable insights. Now I would request our chairpersons to kindly felicitate our esteemed speaker for the day. Thank you for the honors, sir. Thank you so much. Now it's time to felicitate our esteemed chairpersons. And I feel honored and proud to invite Dr. Indu Bhushan, former CEO, Ayushman Bharat, which is the best healthcare schemes catering the needy in India. I would request everyone to help me invite Dr. Indu Bhushan sir to felicitate our chairpersons. Thank you all. Thank you so much for your valuable time and presence. Thank you so much. Thank you, sir. Now it's time to start the scientific session. And for the scientific session of the day, we will be starting the presentation by our esteemed speaker, Dr. Ashish Satav, President Mahan from Merghat, Amravati, Maharashtra, India. Please help me welcome our first speaker for the scientific session, Dr. Ashish Satav. I would request our chairperson to please and honor the stage, Dr. Rajendra Bangal, Registrar MUHS Nashik, and Dr. Rajeshri Khoth, Additional Professor, Department of Medicine, AIIMS Nagpur. I would request, sir, he can kindly start with the presentation.
Good morning. I'm very much thankful to AIIMS Nagpur and MUHS for the kind invitation. Myself, Dr. Ashish Sato, I'm working with my wife Kavita since last 26 years in tribal area of Merghat, which is situated in the northeast part of Maharashtra, around 300 kilometers from Nagpur. My topic is mortality and malnutrition amongst tribal of Merghat, control through research and remedies. That was the picture of our village, Utavli, which is behind our hospital. Mahatma Gandhi said that real India lives in villages and youth should go to village to serve real India. That was our source of inspiration. When I was in 7th standard, I decided to go to some village and serve India. Because of lack of proper health facilities and Meghat and superstition and very low health seeking behavior of tribal, the tribal goes to traditional faith healers where skin is burnt with red iron rod known as Dhamma. All these things leads to very high mortality and malnutrition. The under 5 mortality rate, infant mortality rate, and neonatal mortality rate in tribal area of India is very high as compared to rest of India, even higher than most of the developed and developing countries. The prevalence of severe malnutrition, SAM, as severe underweight, as well as severe malnutrition amongst mother in the age group of 15 to 49 years is higher in Meghat and other tribal areas of India as compared to rest of India and rest of world. This was our first hospital and OPD and first intensive care unit where we were managing cases of brain hemorrhage. And my wife Kavita, she was cooking on chulhas in the hut, and cobras were our regular visitors to our ICU. We are conducting around 11 community-based programs, 5 hospital-based departments, public-private partnership, and policy interventions. When we started in the beginning, because people were not coming to us, so myself and Kavita, we visited around 50 tribal villages of Maharashtra and Madhya Pradesh and screened more than 260,000 people from that area. And now in our new hospital, 30-bedded hospitals, we have treated more than 132,000 patients and conducted more than 5,000 surgeries. Ours is the only hospital for treatment of critical patients in Meghat. And the case fatality rate of critical patients in our ICU is 8.9% as compared to 23.4% of rest of India. While the case fatality rate of critical patients, COVID patients is 16.9%, which is again less as rest of India. And the mortality rates are proportional to the corresponding severity of disease by Apache score 6.4. And we have treated more than 5,000 critical patients like heart attack, brain hemorrhage, malaria, meningitis, tetanus. Because of inadequate medical facilities, like there was no pediatrician in 2004, no gynecologist, MBBS doctor ratio was less than 1 to 20,000, and a mother has to walk at least 19 kilometers to reach MBBS doctors. There was low health-seeking behavior of tribal, poor socioeconomic conditions and superstitions, and hospital services were with limited coverage and impact. Hence, we decided to start community-based care. Community participation is very important, so we arrange regular Gram Sabhas during evening hours. Public patient involvement was started since the beginning from planning to execution until evaluation. Verbal autopsy of around 1,500 deaths during last 14 years has revealed that prematurity and low birth weight are the commonest cause of mortality, seen in 26% of the cases, followed by breastfeeding problems, RDS pneumonia, CNS infections, diarrheal diseases, fever, birth asphyxia, hypothermia, malnutrition, and neonatal sepsis. We conducted our first cluster randomized control trial called Home-Based Child Care Program to reduce child mortality and malnutrition. It was implemented through village health workers who are trained, tribal, local, semi-literate, and married women in 34 villages. They manage childhood illnesses. Around 101,000 episodes have been managed, like ARI, diarrhea, malaria, newborn illnesses like neonatal sepsis, birth asphyxia, and low birth baby. They conducted home-based newborn care and provided intensive behavior change communication programs for nutritional, personal hygiene, antenatal care, and Yashoda Mata breastfeeding technique started by Kavita herself. This was our first training center way back in 1998. Dr. Dani Madam is there. Then we started flip chart education. Injection vitamin K and gentamicin has been given to more than 3,000 newborn babies without any complication. Each and every baby was followed by trained medical supervisors. Kangaroo mother care was provided to newborn babies, especially low birth weight babies, premature babies, and they served babies up to 850 gram or grams in the village itself. They also served many cases of neonatal sepsis in the villages. Because of this cluster randomized control trial, the under 5 mortality rate, infant mortality rate, neonatal mortality rate, and perinatal mortality rate reduced significantly in intervention arm as compared to control arm, and the p-value was less than 0.0001. We tracked the mortality rate from 2004 to 2023, and there were persistent decline in the under 5 mortality rate from 147.21 to 47.33. When we calculated the difference of rate ratio of infant mortality rate and under 5 mortality rate in intervention arm versus control arm, the p-value was statistically significant, less than 0.001. The prevalence of severe malnutrition also reduced significantly in intervention arm as compared to control arm. Our another study was SUBMAN, that is community-based management of acute malnutrition as per WHO guidelines. It was an interventional prospective controlled community-based trial with long-term follow-up up to adolescence. It was implemented through the same village health workers. We provided local therapeutic food and micronutrients Mahan model. More than 4,900 child in malnutrition episodes have been treated. They also treated associated infections like diarrhea, malaria, pneumonia. Intensive was conducted for hygiene, nutrition demonstration, counseling, flip chart, audiovisual, and street play. Each and every activity was weekly monitored by trained medical supervisors. The Mahan local therapeutic food consists of 8 palatable dishes from local produced by local tribal females with local technique. It is available throughout the year. Each 100-gram packets provided 480 to 550 calories and 14 to 17 grams of proteins and 20 to 30 grams of fat. Each severely malnourished child received 4 to 6 grams of proteins per kg per day, 175 kilocalories per kg per day with gradual escalation, along with micronutrients of around 5 grams per 100 grams of local therapeutic food. Behavior change communication was conducted in the form of nutrition demonstration, hand washing demonstration. Lakshmi was severely malnourished on the verge of death. Parents refused hospitalization because of poor socioeconomic conditions. Lakshmi was managed by Mirabai, our 7th standard pass village health worker, who gave injection gentamicin and amoxicillin for pneumonia and sepsis for 7 days, followed by local therapeutic food. Lakshmi recovered completely after 3 months, and we followed her till adolescence, and she is still normal child. When we compared our data with international peer standard, the recovery rate of SAM children was as equivalent to that of international peer standard, while the case fatality rate and default rate was significantly less. At present, the prevalence of severe acute malnutrition in Mahan intervention area is less as compared to rest of India. When we analyzed the data, we found that the recovery rate of SAM was 78.6%, while the recovery rate of severe underweight was 40.52%, and the p-value was significantly less than 0.001. When we compared with control area, it was again less than 0.05. The severe underweight children, when followed up to the age of 5 years, the recovery rate was 78.2%, highest in the world. And when we calculated the mean difference in change in weight for its Z-score in intervention arm versus control arm, the p-value was again less than 0.0001. With government of Maharashtra and government India, we replicated the model in 20 other tribal villages. And in the control arm, there was no change in prevalence of SAM as well as SUW. While in intervention, the prevalence of severe acute malnutrition, severe underweight, and both severe acute malnutrition and SUW was significantly less even during COVID period. And the p-value was again significantly less than 0.001. When we calculated the Z-score seasonality wise and year wise, we found that the mean weight for age Z-score increased from the baseline up to the end of research phase significantly. The final impact was the SAM prevalence reduced by 78.8% in intervention arm. P-value was less than 0.001. The prevalence of SAM has been reduced to 1.65%, and the prevalence of all severely malnourished children reduced to 6.9%. There was statistically significant reduction in prevalence of SAM plus SUW in intervention arm versus control arm with p-value less than 0.001. The case fatality rate during treatment of SAM was 0.22%. We could achieve WHO target of less than 4% of SAM under treatment, and the case fatality rate of SUW was 0.23%. When we followed the SUW children up to the age of 60 months, there was significantly less case fatality rate in intervention arm of 0.9% as compared to 4.62% in reference arm with p-value 0.022. When we followed the treated SUW, their growth pattern and survival was similar to the normal children at the age of 60 months and early adolescence. The major issue in this tribal area is age-specific mortality rate of economically productive age group, which was more than 500 per lakh population of that age group in 2020, which is twice as compared to rest of India and rest of Maharashtra. Verbal autopsy of around 763 deaths during last 16 years has revealed that tuberculosis is the major cause of mortality seen in 18% of the cases, followed by jaundice, heart diseases, diarrhea, CNS infections. Suicide is also one of the major cause among youths, pneumonia, cancer, stroke, and chronic obstructive airway disease. Hence, we started a cluster randomized control trial called Mortality Control Program for economically productive age group, where the key activities were treatment of hypertension, diarrhea, malaria, pneumonia, and asthma and COPD. The village health workers treated more than 125,000 people in the villages. They referred cases of tuberculosis, cardiovascular disease, critical illness, and obstructed labor to hospitals. They conducted intensive behavior change communication programs, and local therapeutic food and antenatal care was provided to more than 3,000 pregnant women. The impact was the average age-specific mortality rate during first research phase of it was reduced to 245.45 in intervention arm, while in control arm it was only 421. During research phase, in intervention arm, the age-specific mortality rate reduced by 40%, while in control arm it increased by 8.7%. And when we calculated the difference of age-specific mortality rate from baseline to end line, in intervention area versus control area, the p-value was 0.0001. During replication phase with government, in intervention arm during COVID time, the age-specific mortality rate increased by 41% in intervention arm, while in control arm it increased by 86.7%, and the p-value was again 0.0008. The prevalence of hypertension was also reduced by 50% in intervention arm. It is cost-effective, acceptable, and replicable model. When we tracked, we have found that the overall significant difference in long-term trends in two arms by chi-square test for linear trend. The difference in age-specific mortality reduction between the two arms was statistically significant, that is 0.001. And during replication phase also, the difference was significant, p-value was 0.0003. one innovative program we started called Counselor Program for Strengthening of 17 government hospitals. This was public-private partnership. First time in India, it happened that government hospitals were monitored by volunteer organizations. It has benefited more than 545,000 people. It has improved hospital delivery rate from 2% to 70% and hospitalization of severely malnourished children from 0.1% to 14%. There was statistically significant improvement in hospitalized severely malnourished children. P-value was less than 0.001 in Meerut as compared to other tribal hospitals of Gadchiroli and Nandurbar. We conducted first community-based study for tracking community mortality due to respiratory syncytial virus with Gates Foundation and University of Colorado, Denver. Our team tracked around 11,000 children in the villages, and village health workers collected nasopharyngeal swab from more than 4,000 severely pneumonia children and more than 200 children who died in the city. And the study has shown that respiratory syncytial virus is the commonest cause of childhood mortality, around seen in 7.45% of the cases. And it is the commonest cause of childhood pneumonia seen in 14.35% of the cases. And the data has been shared with Gavi, which will be used for deciding maternal global childhood vaccination and policies. Reshma was an orphan child suffering from severe malnutrition, severe anemia, cleft lip and cleft palate. Dr. Dilip Gahankari and Dr. Shailesh Nisar from Nagpur, they operated Reshma in Mahan Hospital. And later on, she was put on local therapeutic food and she's the same Reshma after 3 months. Kavita and her team, they have screened more than 460,000 patients across 450 tribal villages. Many times, they are going to villages through rivers with their ambulance and screening the patients. They have screened more than 300 schools in that area. They have prevented blindness of more than 32,000 patients by cataract surgeries and other interventions. During COVID, we treated more than 2,500 suspected COVID patients and more than 173 critical patients. More than 100 critical patients were managed with ventilators and NIV, and the case fatality rate of just 16.9%. We realized that the personal touch and speech of senior doctor is very important. All these 3 patients were suffering from severe ARDS with SpO2 of 60 to 70%, who were on ventilator for 15 days and oxygen of around 70 to 80 liters per minute. In the community during that time, our team treated more than 50,000 patients in non-COVID patients also in the villages, distributed essential material to 80,000 people, did intensive behavior change communication program for 75,000 households, and it has significantly improved the vaccination rate and reduced RSV infections and COVID deaths in intervention arm. During that time, 18 of our staff, including myself, developed COVID, but no one stopped the seva to the patients. To make this program sustainable, we developed more than 11,000 nutrition gardens and nutrition farms in 17 tribal villages, which has produced more than 354,000 kilograms of green vegetables, pulses, and oil seeds. And we distributed around 40,000 plants to the tribals. And we did water conservation activities in those villages, and it has reduced malnutrition. Dr. Abhishek Vaidya from Nagpur and Dr. Gahankari, they have operated a huge case of goiter, around 2 kilogram, 20 centimeter large, 2 years before. After 10 years, the lady has been operated and she is now living a normal life. We have realized that unless until government policies are not changed, we are not going to achieve SDG. Hence, through dissemination of our research, advocacy, and public interest litigation in Mumbai High Court, we could modify around 32 state government policies, including severe underweight are now, Maharashtra become the first state in the world where severe underweight children are being provided special package. Village child developmental centers have been started. Now IS officers has to do compulsory posting in tribal areas after the PIL, and there are special reserved seats for MBBS students who will do 3 years posting in tribal areas of Maharashtra. It has benefited more than 10 lakh tribals and 1 lakh severely malnourished children. Mahan became the first organization in the world to conduct community minimal invasive tissue sampling. Tissues were collected from the dead children and adults from brain, lungs, and liver in the ambulance in the villages. And this study has shown that meats in purpose modified ambulance can be used worldwide community meats, especially in areas which are remote and lack healthcare access. As most of the tribal areas, the deaths are 70% of the deaths are home deaths without knowing the cause of death. So we significantly reduce mortality rates and prevalence of severe malnutrition. The research has been published in 40 international journals, including Lancet and BMJ, and it has been presented into 37 international conferences, including Uh, I was invited as a keynote speaker by Gates Foundation and WHO Public Health Champion Award, COVID Warrior Award by World Economic Forum, and ICMR has given Best Tribal Award. Thank you. All these programs were externally evaluated by external agencies. Harvard USA and UNICEF and Lancet Global Health has mentioned that the initiative started by Mahan has been hugely successful and influential in defining the merits of community-based care globally. The intervention in NGO sector have demonstrated tremendous efficacy and staying power. Evaluation by University of Colorado, USA, and various government medical colleges of India and Nagpur University has mentioned that Mahan has definitely reduced various mortality indicators and malnutrition, and this study contributes to the evidence around sustainable and effective intervention that successfully expand access to health services and improve health outcomes amongst economically productive adult population. Mahan models are safe, affordable, acceptable, approachable, and achievable with local manpower. Mahan models are replicable for reducing mortality and malnutrition in other tribal areas of India. Samman project has huge potential to be generalizable and replicable all over the world, which will help to achieve SDG and WHO goals. Rajmata Jio Mission of Government of Maharashtra and UNICEF has mentioned that highly active Mahan has disseminated information about the high number of child deaths and undernutrition in high burden areas of the state. Their advocacy has resulted into government action, that is creation of Rajmata Jijau Mother and Child Health and Nutrition Mission. It has increased demand on the ground for public services amongst marginalized populations, and the strongest tools that arm this advocacy effort is data showing the high burden and providing solution to reverse the damage. Hilary Pinnock from UK, she has mentioned that innovative work of Mahan Trust is making a real difference to the people Mahan serve. As there are years, I'd like to reveal some key recommendations to Government of Maharashtra and Government India, MHS and AIMS to improve health status of tribals of India. This is after intensive discussion with thousands of people. Home-based child care program should be implemented to reduce child mortality. Community-based management of severe malnutrition with local therapeutic food should be started. Mortality control program for economically productive age group should be started in tribal areas. Counselor program for strengthening of government hospitals with voluntary organizations should be immediately started in all hospitals of India. There should be task shifting in rural healthcare as doctors are not ready to go to tribal areas. All social and health policies should reach the unreachables. Especially, there should be focus on poor children and uneducated mothers. Real status of malnutrition and mortality should be exposed with the help of experts and voluntary organizations and social, because there is gross underreporting of mortality and malnutrition in tribal areas. There should be formation of external vigilance committee and expert committee for monitoring and quality control. Nutrition rehabilitation units should be started in all tahsil places. There should be policy for doctors availability. All tribal hospitals should be affiliated with medical colleges. MUHs should specially start some tribal health courses related to tribal problems. And tribal policy has been framed by government of Maharashtra and around 75 voluntary organizations in Maharashtra. It should be immediately implemented all over Maharashtra. Intensive behavior change communication program should be conducted for health and nutrition. All tribal hospitals should be upgraded to IPH. It should not be only primary care centers. There should be public-private partnership in health sectors. Child treatment centers and village child developmental centers should be started in all tribal hospitals. Kitchen garden and nutrition farms should be encouraged. The tribal health budget should be increased to 5% as per WHO and 7% of state expenditure, and minimal invasive tissue sampling and verbal autopsy should be implemented immediately to know the cause of home deaths. I am very much thankful to AIMS and MUHS, especially to Dr. Chaudhary sir for the kind invitation, and to all of you for your kind attention. All of you are invited to Mahan to bless us further. Thank you.
Thank you. Thank you so much, sir, for such an inspiring insights. We appreciate your efforts and selfless service in controlling the mortality and malnutrition amongst the tribals at Medghat and across India. Thank you once again for your valuable time. I would like to invite our next speaker, Precious Narambi, founder and CEO, Vessels of Virtue, South Africa. Please help me welcome Precious Narambi. Her topic for today is guiding principles for working with tribal nations and organizations.
Good morning.
Good morning.
It's really an honor to be in India. It's my first time, and greetings from Africa. So I am a social entrepreneur, born Zimbabwean. I've been living in South Africa for the past 15 years, left home because of economic challenges in my home country. And I think now, as I'm getting a little bit older, I'm realizing that if there are challenges in my own home country, I must face them head on and try as much as I can. And here for the past 2 days has been such an eye-opener for me, seeing how the Indian community is dealing with their own problems. And I feel like sometimes we are not told the whole story of how beautiful India is and how you've made me feel home. So I'm very grateful to Dr. Sanjeev and your entire team. I feel so honored, and believe you me, there's so much that I've been learning, and I know that I'm going to implement a lot of things when I go back home. So I'm a social entrepreneur. I've run my own organization called Vessels of Virtue for years. I started it to address needs that were prevalent in my community. And we have also been able to run an organization called Elohe Cleaners, which has employed over 5,000 women on jobs. And we are still counting. We are still trying to see how we can scale that across Zimbabwe and South Africa. But the focus of my conversation today is based on the guiding principles for working with tribal nations and organizations. But just to take you a little bit back on the work that we have done, our organization focuses on about 5 pillars of work, which is economic and educational programs for women, which is our first pillar. We have infused that with technology and innovation through different programs from Amazon and Microsoft. That becomes our second pillar. The third one has been the humanitarian arm. The fourth one has been smart agriculture and climate change, that we train women, and women have been our beneficiary for the work that we do. Last but not least is the healthcare bit, which we recently introduced, and our entry point has been insurance programs with the need to then capacitate marginalized communities in my home country, Zimbabwe, and we've been trying to look for medical equipment with the intention of building hospitals. So once again, like I said, there's so much that I've been learning and I intend to implement when I go back home. Back to the guiding principles for working with tribal nations and organizations. I think the guiding principles serve as the foundation for achieving our mission and vision, in ensuring that every initiative we undertake is rooted in integrity, innovation, and inclusivity by prioritizing access to quality healthcare, sustainable business practices, gender empowerment, and community-driven solutions. We create lasting impact in marginalized communities through strategic partnerships, evidence-based approaches, and a commitment to excellence. We remain steadfast in transforming lives, fostering resilience, and driving meaningful change. Our principles are not just values, they are the blueprint for a healthier, more equitable, and empowered future. And often an integration of both stakeholders makes more sense. So on my first point is respect tribal sovereignty and self-determination. In some of the work that we have done, because you can imagine when we moved from a majority of us due to economic challenges, when we moved from Zimbabwe going to South Africa, a lot happened. Just that movement alone left a lot of people, women unemployed. It disintegrated the family unit. A lot of children were not then able to go to school. So when you do the support that you do, if you do it in isolation, it then ceases to serve the point. I think holistic empowerment is always or should be the main drive force of the work that we do. So respect tribal sovereignty and self-determination, recognize tribes as sovereign nations with the right to govern themselves, follow tribal laws, policies, and decision-making processes, engage with tribal leadership and designated representatives before initiating projects. And I promise you, there are some projects that we did in isolation of the tribal sovereignty, and they didn't yield as much result as we would have wanted, because then at the back of our head, we are having a perceived solution to the problem that we think is there, but without necessary engagement with the beneficiaries, sometimes then there is not so much progress that you achieve. Build meaningful trust-based relationships. That's number two. Invest time in developing trust and mutual respect. Approach collaborations as long-term partnerships rather than short-term transactions. Honor commitments and be transparent in all dealings. You know, some statistics in my home country show that some of the organizations that have been funded, they lack transparency, number one. Number two, you can't really measure. And number three, some of them, you end up they're not having the real impact that you want to have, because then there is no transparency in the dealings or even the funding that is being given or provided to certain initiatives. So there must be transparency. I think we must always operate from a place of authenticity and genuine interest for the betterment of the community we want to serve. Number three, engage in ethical and culturally appropriate practices. Learn and respect cultural traditions, protocols, and community values. Seek guidance from tribal leaders, cultural advisors, and local leaders. Avoid actions that could be perceived as exploitative or disrespectful. And even as I've been sitting here and watching, observing, and learning, I've been seeing that there is always something that the older generation has to pass to us, and there is always a need for us then to appreciate what different age generations are bringing on the board for the growth to be sustained, for the impact to be sustained, for relevance to be sustained in the work that we are doing. And guiding principle number four, ensure inclusive and equitable participation. Include tribal members in planning, decision-making, and implementation. Prioritize community-driven approaches rather than imposing external solutions. Recognize and respect diverse perspectives within and across tribal communities. I think it's important to include the people, and I think some of the examples that we've been seeing here, we have been seeing how some of the work people are directly engaging the people that are in the community, and I think that brings about ownership to the work that one is doing, and people can actively write something that they feel that they are part of. Number five, honor traditional knowledge and intellectual property rights. Seek permission before using tribal knowledge, data, or cultural symbols. Ensure fair compensation and acknowledge for shared knowledge and contributions. Respect confidentiality and data sovereignty regarding tribal information. As I've been home the past 2 months setting up our organizations, one of the key things that I was told, because we got like 60 hectares of land that we want to try and use for farming, again, to try and empower the women in our community that we have identified to do the farming programs in. And they were telling me some of the myths, the stories that behind some of the mining initiatives that people have come to do. And they'll often tell you that people would separate a mountain, and when they come tomorrow, the mountain will be, like glued together. I don't know if something like that happens here in India. And so they would continuously come and try to do the same thing for a long period. And then the mountain, the following morning, they'll find the mountain glued together. So then you'd realize that it's because people are not honoring the tradition of that community. They've not gone through the system that works of the elders that are already set. And they are not in consultation to fully understand what works and what doesn't work within that period. So I then encourage you and I, as we do the work that we are doing, that we must honor tradition, knowledge, and intellectual property rights. We must seek permission before using tribal knowledge, data, or cultural symbols in the work that we are doing. My guiding principle number 6 is support economic and community development, collaborate on initiatives that align with tribal priorities and benefit the community, strengthen local workforce development, education, and business opportunities, promote sustainable solutions that respect tribal land resources and traditions. So in the work that we have been doing as vessels of virtue, I think initially we were just focusing on one arm, and over a period of time, we then realized that there was need for a woman to be holistically empowered to evolve as a person for personal growth, for business growth, so that the women that we work with, they can be able to measure the work that they are doing. They can also be able to contribute positively to the economic growth of a nation. But once the formal structures are put in place, then that can be quantified. And number 7, commit to transparent and ongoing communication. Maintain an honest and regular dialogue with tribal partners. Be clear about goals, expectations, and potential challenges. Provide accessible and culturally relevant information in all communications. I think when communication is not there, there is often assumptions. So when we are going out to do what we are doing, we must then make sure that we are transparent and we have ongoing communication with the people that we are trying to assist. Number 8, we recognize and address historical and systematic inequities, acknowledge past injustices and their ongoing impact on tribal communities, work collaboratively to support healing, empowerment, and self-sufficiency, advocate for policies and practices that advance equity and justice for tribal nations. One of the project that we started at some stage was to set up an ECD, Early Childhood Development Center, for foreign nationals that were struggling with sending their children to school. And I think we had not done enough consultation to see if this works or if it doesn't work. And believe you me, we put so much effort in trying to set that up. And on the day when we wanted to open the session, the place was closed. The community did what we were trying to do. So I think then, for me, the lesson from that was that there must be continuous engagement with the beneficiaries to see that what we are trying to do makes sense for them. And number 9, respect tribal land and environmental stewardship. Recognize the deep connection between tribes and their lands, water, and natural resources. Follow tribal environmental regulations and sustainability practices. Support conservation efforts that align with tribal priorities. Number 10, be patient, flexible, and committed to long-term engagement. Understand that tribal decision-making process may take time. Adapt to community needs and be open to evolving partnerships. Demonstrate a long-term commitment to tribal well-being and success. You know, sometimes from my experience, we take the work that we are doing to people and we have our own perceived ideas or solutions of how to solve those problems. I've seen that sometimes because they have no understanding of what we are trying to do, because maybe there is not enough lobbying or awareness to what we are trying to do, they can easily also resist. Then that's where sometimes I think patience comes in, when we have to be patient with the community. You are flexible with the people, you're trying to meet them at their level so that the efforts can really make sense. They are not resisted, they are not denied, but they are actually appreciated. So I've put down some few examples that I thought could make sense. An example number 1, for instance, before launching a healthcare program in a tribal community, an organization meets with the tribal council to obtain approval and align with tribal regulations and integrate traditional healing practices into healthcare services. That's number one. Then it means that the work that one is doing, you have integrated it with the people, they have their input, they have ownership, they can buy into the thing that you want to do. And example number two, a non-profit interested in improving maternal health in tribal areas spends months attending community events, meeting with the elders, and listening to community concerns before proposing a project, ensuring trust and collaboration. I think that, like I said earlier, if we completely throw away, especially for me in our African context, we had a tendency of throwing away what is our history and our culture. And sitting here and learning from all of you has been that an infusion of our history, an infusion of our culture into the new ways of doing things. It means that a people are evolving, a people are growing, and then it then makes sense. There's growth, it's progressive. There's nothing that is left behind, but it's all inclusive for the betterment and the improvement of that community. So I'm also learning, even as I sit here, that it's very important to carry what the older generation, our forefathers, have done into what we are doing now, without doing what we are doing in my generation in isolation of what the older generation have done. Then my other example is that a researcher conducting a study on indigenous medical plants consults with tribal elders, follows cultural protocols, and ensures the benefits from the study's findings instead of solely publishing for academic gain. So it's always, I think, from a place of authenticity, genuine interest to build and develop a community, to build and develop a people. And I think when it's from the place of authenticity, people won't resist. And in summary, in a world where inequality persists and access to essential services remain a privilege for few, we stand as a force for change, all of us. And I often feel like, the inequalities, the injustices that we see in our community, when rather than waiting for someone to save us, we are the people that must actually take on those inequalities, those injustices, hands on, begin to address those things. And as we unpack them, evolution happens, change happens, improvement happens, we become a better people. We are guided by a bold vision. We are redefining healthcare, economic empowerment, and social transformation, creating opportunities where they are needed most. Our commitment goes beyond service delivery. We are building sustainable solutions that empower individuals, that strengthens communities, and drives systematic change, rooted in innovation, in integrity, and impact. Our work is not just about addressing immediate challenges, but about shaping a future where no one is left behind. I think it is possible that we can not leave anyone behind, that in this trajectory of improvement in our different communities, in our different continents, we are taking each and every one with us. And my challenge in my parting words is that you are the person that you are waiting for. You are the change that you want to see. There is no savior coming. You are the savior for yourself. You are the savior for your community. You are the savior for the continent. And our united efforts individually bring about the change that we see. Thank you.
Huge thanks for the fantastic talk and for sharing your knowledge, ma'am. Your expertise on the subject was really enlightening. I would request all the delegates sitting in the audience to kindly fill the feedback by scanning the QR code provided. So for the next session, I am glad to invite our distinguished and enthusiastic speaker, Dr. Devendra Khandait, India lead Bill and Melinda Gates Foundation, all the way from USA. Please help me welcome Dr. Devendra Khandait. Sir.
So thank you for the enthusiastic mention of my name. Couple of changes. I work in India. I'm based in Delhi, and I lead a cluster called a State Health System cluster. I lead for that cluster. Uh, First things first. Thank you, organizers, um, AIMS Nagpur, for inviting us for this very, very important symposium. I don't know, matlab, the people with the 5 feet has always got a challenge ki whether to see at the screen or at the audience. Let me make some adjustments there. Uh, I think I'm being. I think let me particularly thank Dr. Sanjeev and the whole organizing team for gathering the galaxy of the speakers and the audience on this important topic. I think this is just an amazing, amazing thing that is happening. Being the son of the soil, I feel particularly happy about this happening. Before I speak on the ideas in tribal health, some of the ideas, not all, cross-pollination of ideas in tribal health, let me talk about Gates Foundation in a minute. Um, as an organization, we believe that all lives have equal value. Whether you are from here, somewhere else, whether you do have right opportunity, whether you are economically empowered, unempowered, etc. Everyone deserves an equal chance to be have the productive and the healthy lives. Guided by this principle, in the Gates Foundation India office, on variety of things, but our primary approach is help build and strengthen the equitable health system. Because once you develop the platform of the health system, that will support not only the general population, but that will also support the marginalized, the tribals, several segments which are generally disadvantaged. Generally, we work on reducing the select infectious disease which are otherwise neglected, like visceral leishmaniasis, lymphatic filariasis, tuberculosis, etc. Of course, SDG goals, NMR, IMR, MMR becomes one important theme. We believe that gender equality is such an important precursor for everything that we do in the health space. And that's why that's the focus. And in addition to that, financial services, agriculture, sanitation, these are some of the areas where we work. Because we are an American philanthropic foundation and we desire to have an impact at scale, our primary work is under the leadership of the respective state and the national governments. And that's why we work in support of the government vision, and general partners are non-profit organization, private sector, academic institution, multilateral, domestic philanthropies under the overall stewardship of the government. And coming to the central topic of cross-pollination of ideas, and when I'm speaking, I was thinking which hat I am wearing. And this is a mixed hat of the Gates Foundation, public health professional, a person from this area in India. Significant part of my professional life, I worked in several places in polio eradication in several districts in India. So thought is there are several challenges, and you have heard a lot of speakers speaking about very detailed challenges. But I think we think that there are three challenges. One is the access. Availability of services is the key issue.
availability of a quality services. Second is cultural practices, socio-economic barriers, and the trust related thing. And many times we do have a compassionate models which has done tremendously to improve the lives of the tribal population in a select geography. But important is how do we contextualize such models at scale? And I think to us, these are the three challenges or the three issues around which our thinking about the tribal health is all about. And that's why I am picking up some things and some models from various parts of India which try to address such issues. These are not the only models, these are not the only solutions. There are several and thousands of solutions. We have picked up one we thought which has got the potential to do the impact at scale and which is celebrated as an impact at scale. I am acutely aware that when I am speaking here, there are several noble-hearted people who have led the lives and who have put their entire life in the support of the tribal population. And I am acutely aware of such stalwarts. And many those models may not represent here just because I am talking from a purely a larger impact at scale lens and a scalability lens. So let's talk about the first issue, that is access and the availability of the services. And we thought, why don't we share when I was developing a curriculum for Lal Bahadur Shastri Administrative Academy for IAS officers L4 training, and the model which we have used for access was Bijapur model. I asked Tamboli, the administrative IAS officer of Bijapur district then, had in consultation with the directorate and the partners, had come up with the model for addressing the shortage of clinical specialties in the facilities in the most remote areas. And what is this model? And before coming to that, I just wanted to share some data where over the next, and this is the published data and I'm using that, over the 4-5 years, there was exponential rise both as outpatients as well as inpatients. The places where having a medical specialist in an entire district was a challenge, you could see 50, 100, 200 indoor facilities and the operations being conducted. Imagine a 3 specialists in 3 districts of Bijapur, Dantewada and Sukma, some of the most access compromised districts. Within 3 years, from 3 they could get 40 clinical specialists, surgeons, gynecologists, anesthetists, orthopedicians, etc. Number of the staff nurses and A&M just exponential jump. So what did they do? One, of course, we can continue to say that money is not important, but money is the first thing. They provided financial specialists received up to 20 to 40% higher salaries than regular pay. Professional benefits, bonus mark for post-graduation admission, flexible leave policies. Most important is living condition. If a MD gynae goes to Bijapur, where does that gynae stay? So the district collector, in partnership with the several departments, they did residential facilities. SIHFW training center was converted into a reasonably well-placed residential place, swimming pool, library, and everything other facilities. Internet, transport facilities. Doctors needs finally professional satisfaction. You can bring the doctor, but there is no operation theater, there are no equipments. So they made an effort to bring everything together. Generally, once the people are posted here, they don't know when to come back. So they were given a specific time by which they will be coming back. And that's why what you saw in the earlier slide, the numbers, this is the product of that number. But this was done primarily with the leadership of a district magistrate and the Directorate of Health. They use every fund which was available with the tribal population: mineral funds, forest funds, health. And it was not only the health, it was the every possible funds that were available there. Now, many times people say, what is public health? And I often jokingly say, public health is a subject of common sense. Many times, whether we are willing to address the issue by using the simple logical, measures. This is not a rocket science. Somebody just took a leadership and they brought it together. I will take another example. You bring the doctors, you bring the specialist, but they don't have a sufficient confidence to do the operations or to do the surgical procedures. And that's why it is not from the tribal example, but it is the example of effective task shifting, what is called as buddy-buddy model. And that is significantly used in Uttar Pradesh for FRU activation. I just want to say that through that buddy-buddy model, there is 230% increase in the functional FRU in 4 years, and 582% of them are the CSC FRUs. So what is buddy-buddy? It's a pair of doctors with the complementary skills, anesthesia and obstetric surgery, to conduct the cesarean section. And when I say cesarean section, it is just ability to handle emergencies for the obstetric care. Those doctors were identified. Those doctors were put for a training. They said, oh, we don't have sufficient confidence. Okay, then they were put in a place with an experienced anesthetist and experienced gynecologist. And they will provide that counseling in person for 3-4 months, but at the same time, over the period of say 1 year, they will continue to mentor them and handhold. This is all about buddy-buddy model. And I just wanted to share one. Okay. This photograph of Dr. Amit Tripathi, he is not MD Gyne. He is an EMOC trained doctor who has conducted, and this is a photograph when he conducted 100 cesarean sections. And through this buddy-buddy model, we can continue to say that there is a shortage of specialists. But are we doing then effective task shifting and mentoring them and handholding them? And this was considered a GOI best practice in 2019 as a buddy-buddy model. This is about facilities. I am coming to the outreach. There is opportunity available for community through the community health officer. It is said that any population which is at the cusp of transition is the one which will face maximum challenges in everything, in NCDs as well as others. So to say that, oh, there will be no NCDs in the tribal population cannot be accepted. So there is a community health officer. Now this is through the Ayushman Arogya Mandir. These are generally the nurse and which has gone a public health training, and generally they will do the clinical role, public health role and the managerial role, and they will try to solve several issues. I think this is opportunity which is available, which is just one grade above the frontline worker. Are we using this opportunity to improve our outreach services in the tribal areas? I have talked about the access issue. I will take one more example for the trust and the cultural economic barriers issue, and I have combined this. It's a participatory learning and action, and I have chosen the model, Exute model from Jharkhand. What do they do? It's a community capacity building process in which the adolescent girls, pregnant women, mothers, they meet periodically, usually once a month. Also invite the main and the frontline worker to provide them learn, plan, carry out and evaluate the activities related to the issues concerning their well-being in a participatory and sustained needs. It has been effective, and I think there are several publications both in Lancet and WHO Bulletin which has underscored the importance guided with 30 to 70% reduction in different indicators. I think finally, at the end of the day, are we involving the tribal community in contextualizing their own solutions? Before I close, I just want to say that these are not the only models. There are several models in India. These are context specific. For example, Asha Plus model, Chhattisgarh Mitani, which is, and the search model, which has then expanded as Asha model. Tribal health integration model, both Jharkhand and Madhya Pradesh. Tribal model from search. Mobile medical units in multiple states. Janani Express, pre-ambulance services, Madhya Pradesh and Odisha. Tribal health and nutrition camps, Tamil Nadu. NGO run, you just heard Ashish Satav speaking about Mahan model. You have heard Prakash Amte. You know, Dr. There are Chhattisgarh. In Chhattisgarh, there are several models. In different parts of Maharashtra, there are several models. These are run by public health stalwarts, nation of curative, promotive, and curative, preventive, and promotive care. But the word is, they are charismatic leaders, and there is a strong empathy. Now the question is, can we create several such leaders in all parts of India? Probably no, and that's why we will have to take the best of the lessons from this model. You have to take out the personalities and you have to contextualize for the scale. See, I think many times people say that telemedicine is a solution for all the access issues for the tribal population. I do have a challenge in accepting that. That can be a supplement. That cannot be at the cost of, oh, we will not put doctors, we will. Telemedicine is a very important model. It is in support when there are specialists and the other health paraphernalia is available. I don't have any rocket science learnings. I just wanted to say, whenever you are developing the tribal health models, health of our community lies in honoring the wisdom of our ancestors. Don't forget that these are the tribal communities. They know what matters to them. Everybody knows what matters to them. So how do we honor the wisdom of our ancestors? How do we use the strength of our present? And how do we end the promise of our future? How do we combine all three? And how do we come up with the model which is applicable and contextual for that setting? We cannot say that health services, the people will have to come to the health services. You will have to develop the model where you will put the people in such a way that people and the facilities will be closer to the population, so that the population doesn't have to travel a long distance. Bijapur model says there are multi-sector. When the multiple sectors are combined, coming together, that's when we can say that, okay, we can take the best of benefits. Community-led approaches, cultural sensitivity, technology can bridging the gaps. These are all, I think I'm not telling something which is rocket science, but whenever we are developing the models, these are some of the things which will come together. I think I just want to give you a last example before I close. I was working in Madhya Pradesh, and there is a Baiga community which is dominant part of eastern Madhya Pradesh, northern eastern Madhya Pradesh. And whenever I will go and try to understand how is the health situation, Baigas are known for not speaking lies. They will speak the truth as it is. And generally, many of the colleagues which used to accompany, one of the common feature was, they don't have to be that way. And my answer to them was, by honesty is such a virtue, and they are displaying in the 21st century, why can't we develop the model which is more appropriate for them, in such a way that they can thrive in such atmosphere. Lastly, I just wanted to thank you, but with the quote from Nelson Mandela, health cannot be a question of income. It is a right. just because I do have more income than others, I do have more right. Thank you so much.
Thank you. Thank you, sir, for sharing your perspectives on the topic. We all appreciate your exemplary and magnanimous work. Thank you, sir. I request our chairpersons to sum up the session.
So a very good morning to all of you, and it's a great privilege for us to chair this dynamic session. Yesterday we had very interesting sessions on gene therapy, genetic modification, and advance. And now today we have come back to basics with Ashish speaking on malnutrition in Melghat. And I would like to share with you that Ashish has been a student, and I feel very proud to be chairing his session. And both of us share our first international publication where Ashish did all the legwork and I just wrote the manuscript. So thank you, Ashish. And I've seen his journey right from the beginning when he started his journey in Melghat. He settled there and he decided to serve the tribals. And it's been a really very hard work and dedication. And now he has come up to this level where he has made a significant difference in the malnutrition in Melghat and also in reduction of the mortality. So what struck me most in his was that there was a highest malnutrition rate in Melghat as compared to the rest of India. And through a very structured approach, he has tackled this, he has brought down the malnutrition rate, and he has also proved it by, documented it by presenting a proper data. Another thing is increased mortality in the economical productive age group. So that also he has been a very, his hospital, they have been treating very complex cases. He has treated very critical patients and given them a lease of life. And thank you for bringing down this mortality rate. So Ashish, hats off to you. And it's been a very inspiring lecture and all of us should feel inspired and definitely visit Melghat once as he has invited us. So thank you so much, Ashish. As far as Prisha's lecture is concerned, the first, she has given us the guiding principles for working with the tribal nations and organizations, and they have been very apt and they have been brought out by doing a lot of research and a lot of work. So thank you so much. And two things which I would like to say, which has been the crux of all these meetings, is that respect tribal sovereignty and self-determination. That is the first thing when we start working with the tribal population. And another thing which he said is invest time and give a long-term commitment. And that is what Ashish has also done. And that is what all of us do to bring about a significant change in their lifestyle. Dr. Devendra Khandai, sir, has also really given a very inspirational talk, sir, and your models are definitely worth implementing, and they would definitely guide us in doing our work in the tribal area. And what he said is, the first sentence really touched everyone's heart, and that is that all lives have equal values. And that is why, and one thing is gender equality is important whenever we work with tribals. He has given us so many models, we should act on those models, use those models, and of course, he'll be there to help us at every step in life. So all the three speakers have given wonderful messages. And in the end, I would like to say what Prishya said, that we all look forward to shaping a future where no one is left behind. And that is when we would have achieved a true equality. So thank you for this very wonderful session. I hand over the mic to Dr. Rajendra for his comments.
Yeah, thank you very much. I'll talk about the first speaker, Dr. Sato. I was not at all surprised by speech when I learned that he is a product of MGIMS Sevagram.
GNC.
No, yes, this GMC Nagpur. Okay, okay. Because in his talk, he had mentioned about MGIMS Sevagram, and the thing is, era of almost 40 years back that flashed when I was a student of that particular college. We used to do this community-based care, and verbal autopsy, home-based child care. So whatever was practiced at that time, he is actually implementing it, and I definitely congratulate him. And please keep it up, Dr. Satav, sir. Another important thing about his speech was the efforts that were uh, in changing the Maharashtra government policies as far as these issues are concerned. And the recommendations on tribal health was they were very appreciated. Second speaker's speech was very precious, and it was a sincere and honest presentation. What I felt, because first of all, I will appreciate her for appreciating beautiful India. Thank you very much, madam. Her speech was in the form of a blueprint, which included respect for tribals and one thing, that is long-term partnership rather than the short-term transactions. So definitely, ma'am, this may be a conference or a symposium, may look like a short-term transaction. However, definitely you will see the long-term outcome from this symposium. Yes, Honorable Chief Minister of Goa, what he uttered, the same was reflected in this. You might not have understood. He spoke in Hindi. That is, the tribals are the owners of Jal, Zameen, Jungle. What he meant to say was, it is not we, but the tribals who are the owners of water, land, and forests. The same was reflected in your speech. Thank you for this. And also, thank you for finishing 56 seconds before time. Yeah.
I thank our chairpersons for such a
Yeah,
precise.
one
Okay.
sec about Dr. Devendra Khandait's cross-pollination of ideas in tribal health. Sir, you started your speech with by saying that which hat you should wear. You are wearing multiple hats, but after listening to your speech, I definitely will advise that you should keep on wearing all the hats, whatever are with you, and what could be the more practical example than our honorable VC ma'am, who wears three hats. She is not here, so I will take the chance to say in her absence, oh, she wears three hats of a soldier, a teacher, and a doctor. So, and they keep on changing. वो जादूगर होता है ना, magician. When she is talking with a teacher, then the color of the hat, it changes. So you please keep on wearing all the hats, and thank you for the Badi Badi model which you mentioned. Definitely we will convey it and we will practice, we will try to implement it in the state of Maharashtra by taking it to the administrators. Thank you. If there are any questions by the audience to any of the speakers, you can ask one or two questions. If not, then ma'am, please continue.
Hats off to our chairpersons as well, who very precisely and enthusiastically summed up the session. I would like to invite the esteemed speakers to please come up on the stage for the felicitation. Dr. Ashish Satav from Melghat, India, Precious Nerambi from South Africa, and Dr. Devendra Khandait from USA, but Indian by heart. I would request our chairperson to felicitate our speakers. Thank you. From the bottom of my heart, I thank all the speakers for their valuable time and for sharing their knowledge with us on such a great platform. Thank you. Now, I would like to invite a personality who most importantly to mention about and appreciate the courage he displayed in traveling to India all the way from Palestine. Looking at the spirit of the conference and stature of this academic platform, Sir was undaunted by the daunting challenges before him and he decided to be here. Please help me welcome Professor Dr. Ala Azmi Ahmad, Adjunct Professor, Pediatric Orthopedic, Palestine, Polytechnic University, Palestine and Medical University of South Carolina, USA, to felicitate our chairpersons. Thank you, Professor. Thank you so much. I thank the chairpersons as well. Thank you all. I would request a display of the QR code for the feedback. Dear audience, we value your feedback, so kindly scan the QR code and share us your feedbacks. For the next session, I am glad and honored to invite the chairpersons, Dr. Mrunal Phatak, Dean Academics, Professor and Head, Physiology Department, All India Institute of Medical Sciences, Nagpur, Dr. Manisha Kotekar, Member, Management Council, Maharashtra University of Health Sciences, Nashik. Please give them a big round of applause and help us invite our chairpersons on the stage. Welcome, ma'am. I'm glad to invite the upcoming speaker, Dr. Sanjay Zorpe, President, Public Health Foundation of India, from India. Sir would be speaking on integrating tribal health in professional health education in India. Welcome, sir.
Very good morning. Distinguished Chair, Professor Phatak, distinguished delegates, and ladies and gentlemen. At the outset, let me express my gratitude to Professor Madhuri Kanitkar, Professor Prashant Joshi, and Dr. Sanjeev Chaudhary for this extraordinary opportunity to reflect on some of the issues in the context of mainstreaming tribal health in health professional education in India. We generally struggle to understand what kind of health system that we need. We need a health system which is stronger, sustainable, effective, resilient, responsive, but also culturally sensitive. But such health systems are impossible without adroit, motivated, and competent health workforce. And when we talk about the architecture of the health systems, human resources for health workforce is one of the very critical building blocks. It also includes the health service delivery, health information systems, health financing, leadership and governance, and so on. But the cascading building block remains the health workforce. But then what constitutes health workforce when we talk about health systems, particularly in the context of India? We can put them in 8 buckets. This is what is the Indian health workforce is all about. We have doctors, both of course allopathic and Ayush professionals, nursing professionals, public health professionals, pharmacists, dentists, allied health professionals, funders, and also we have other support staff. What about these 7 buckets except the other health workers or the staff? The role of the health professional education is critical and important. And when we actually talk about health professional education in the context of the health workforce development and their capacity building, there are 2 approaches that we need to deliberate upon. Generating sufficient human resources for health. One is a pre-service capacity building where the role of the health professional education is critical and important. And then the in-service capacity building. I will first dwell upon the pre-service capacity building health professional education because we are talking about mainstreaming tribal health as a part of the health professional education. If you decipher the supply side of health workforce in India, it has tremendously increased in last 1 decade or so. Currently, the intake capacity of health professional education institutions in India is around 1.3 million. That has significantly increased in last few years or so. There is an increase in number of seats in medical schools, nursing professionals, allied health professionals, and public health, and so on. And when we talk about mainstreaming tribal health in health education, we are talking about annual intake capacity of around 1.3 million students being added to the cohort of health professional education. In terms of understanding the supply side of public health professionals, it's more than 10,000 is the intake capacity of training institutions which offer programs in public health in India. And therefore, largely when we talk about health professional education, these are the numbers that we talk about. But Lancet Commission, which dwelled upon in 2006 and reflected on the status of the health professional education globally, particularly the situation in the 21st century, it has been very rightly articulated that the health professional education has not kept the pace with the 21st public health challenges that we are confronted with. And therefore, it is clearly needed a very thorough and authoritative re-examination of the health professional education in the context of the current challenges that we are confronted in the 21st century. If you look at the literature in the context of health professional education, particularly mainstreaming tribal health, we all would agree that there is a limited focus on tribal health in health professional education. The curricula has often overlooked the specific health needs of the tribal populations, resulting into a knowledge gaps amongst the healthcare providers who are critical and important in providing healthcare services. They are not adequately trained to address unique needs of the tribal populations, leading to inequitable healthcare delivery. These are issues that one can see. And therefore, Viroj has rightly said that a public health education in the context of the health professional education is irrelevant to the national health priorities and diverse from public health practice, is useless and constitutes a lost opportunity which should be kept in mind. I will dwell upon 3 critical and important issues when we talk about mainstreaming tribal health in health professional education. The first one is about the cultural competencies, the limited focus on the cultural competencies in the professional education. They are not sufficiently addressed and engaged as cultural, linguistic, and traditional health practices of the tribal communities. With very limited understanding of the local knowledge systems that we expect them to do, and therefore, we need to have culturally relevant content of the curriculum that we talk about, the case studies and clinical experiences when we wanted to really mainstream the tribal health in health professional education. It is also important to understand the difficulties in providing the appropriate and culturally sensitive healthcare, which remains critical and important. And of course, the exposure to the faculty in terms of an expertise in tribal health and cultural competence, therefore, is important. The next important issue is community-centered approaches to the health professional education. Also lacking emphasis on community participation, empowerment, and collaborative care, which is critical and important. Mainly, it is focusing on hospital-based care, neglecting community issues, which are crucial and critical for tribal populations, advancing the health of the tribal populations. The third important highlight that I wanted to mention is about the multidisciplinary knowledge and multi-sectoral applications needs to be integrated as a part of the health professional education. Because we all understand that health is so clearly linked up with education, culture, livelihood, environment, and economy, particularly in the tribal context. And therefore, health cannot be in isolation. It should be looked at in a much more integrated way in the context of linking it with education, culture, livelihood, and environment. What Professor Sir Michael Marmot tells us about the social determinants of the health, that the conditions in which we born, live, grow, work, and age have influence on the health of the populations. And therefore, in isolation of the social determinants of the health, one has to look at the purposes. And therefore, the approach needs to be shifted from disease models to much more holistic health model. And collaborations remains critical. It's important that the institutions working in the tribal welfare, social welfare, engage with health professional institutions also. Therefore, mainstreaming of how it actually needs to be done, because what is to be done is one aspect, that how it needs to be done is by revisiting the curriculum, the competencies, bringing focus and issues to the tribal health and health professional education, also designing and developing packages, case studies which are the tribal health. As I mentioned, shifting the content and competencies from the disease model to the holistic healthcare model. Exposure to students are important and needs to be reflected both undergraduate and postgraduate students. Certificate programs like, for example, electives need to be looked at. Faculty development should also be at the center stage. New institutions opening up in tribal areas. Seats, opening up additional seats in tribal populations for the health professional education institutions. Connecting tribal health research to the education also is important. Creating chair professors and center of excellence in health professional institutions could be another way of looking at it. Strengthening institutional capacity also is an important hallmark for advancing the agenda of mainstreaming. Engagement with professional councils, universities, and institutions are some actually areas where probably we can focus upon when we talk about mainstreaming tribal health as a part of the health professional education. And there are recommendations, like for example, this is the Government of India Human Resources for Tribal recommendations include several recommendations, but in the context of the HRH, one of the recommendations is ensuring the availability of the seats in medical schools for tribal youths and other willing to practice in tribal areas. We are opening up dedicated medical colleges in tribal areas. They also talked about Bachelor of Tribal Health program and reservation of seats for tribal people willing to serve in tribal areas into the programs. The another model that World Bank supported, Health Systems Project in Karnataka, focusing on how do you make ANMs available in tribe, where they have 10 seats being reserved in each district for the tribal girls who can actually are willing to work in tribal settlements where no ANMs are posted, and thereby responding to the need of the and positioning the ANMs in tribal areas is another model that we talk about. At the Public Health Foundation of India, we joined hands with Infosys Foundation and designed a program where the MPH graduates, their full education is supported through the fellowship program, and we expect them to work in tribal areas, and their salaries are also being covered for the 2 years, where we expect them to have 2 years exposure into the tribal areas to understand the public health challenges and problem in tribal areas, but also aligning those then subsequently in solving some of the problems. And we aligned with and we worked with 9 NGOs work in the tribal areas to position these MPH graduates to work in the population, tribal population. Capacity building of in-service professionals is also equally important when we talk about mainstreaming. In the size of the Indian health workforce is around 6 million or so. And we have to really see that the existing health workforce also is trained in the context of the tribal health problems, with the training programs related to the tribal health issues. And focus should be on both public and private sector programs, where the role the health professional education institutions and professional associations can play an important role also. When we talk about mainstreaming tribal health in the context of health professional education, the impact would certainly be visible in terms of improving healthcare access, we will be able to address the cultural sensitivity and trust, enhance community engagement, improve health outcomes, and reduce health disparities. But to have the positive impact on the health outcomes, the professionalization system must design new instructional and institutional strategies for advancing the larger agenda of reforms for health professional education. When we talk about new institutional and instructional strategy, when we say institutional reforms will contribute to the transformative learning. And when we say institutional reforms, they will actually advance the agenda of interdependence of an education, which will formally actually translate to transformative and interdependent professional education for equity in health. Transformative education is so critical and important when we talk about mainstreaming, because the time has come really to move forward from informative to formative and from formative to transformative learning. Because we really understand that informative learning, which means integration of information and skills, would be able to produce the experts. But the formative learning would add actually the socialization and values and morals and ethics, which will help us to create the professionals. We need first than experts. But a step behind with transformative learning, when we talk about change agents, leadership attitudes will create the enlightened change agents. And therefore, moving from informative to formative and from formative to the transformative learning will help us to advance the agenda of creating experts to the professionals and professionals to the enlightened change agents, which actually is being recognized as a fundamental driver for the health professional education for the 21st century reforms, which are important and critical. And I also say that we should really look at that the mainstreaming of tribal health in health professional education in India should contribute to the larger agenda of health assurance and sustainable development. And when we say health assurance, it has two words, health and assurance. It is the assurance to the tribal population of this country about their health, the health they dream, desire, deserve, and demand. If that is being fulfilled, then we will be able to create Swasth Bharat along with Swachh Bharat and Sashakta Bharat. Thank you so much for this opportunity.
Thank you, sir. We are privileged to hear such a captivating talk. Thank you once again. Soon I'll be getting the next speaker lined up. So for the next session, I cordially invite Dr. Yogesh Jain, ex All India Institute of Medical Sciences, Delhi faculty working in rural area of Chhattisgarh since last more than 15 years. Please help me welcome Dr. Yogesh Jain, sir. He has been working in Chhattisgarh area since last 25 years.
Thanks for asking me to speak here. I'll take a few minutes to discuss some of the observations that I've been making in my work over the last 25 years, where I went to in Chhattisgarh after a brief stint as a faculty at AIIMS Delhi, with equity as a concern that in healthcare. And thus, because as I realized that Adivasis were among the most, at the bottom rung of the inequity spectrum, if I may call that, we started this work in Chhattisgarh. And as a public health physician that I became from what I was a specialist pediatrician, I observed that, health of the question that emerged was whether one should be only looking at health of the tribals or health of the people in tribal areas, tribals, because often if you want to exclude that, then there are challenges that you would have. We realize that tuberculosis rates could be twice, if not 5 times that of a non-tribal area, that NCDs are no less, but they have a different phenotype that I'll come to. The nutrition that they occupy the lowest rungs of the pecking order of food intakes, or that we know, and the usual label of malaria, Maoism, malnutrition, forest, and extreme poverty all occurring together sort of seem to underscore our work. And if you can see this pecking order that I was talking about, whether it is the particularly vulnerable tribal groups to the regular non-PVT to Dalits to backward caste to others, you could see a sort of a graded pecking order, as if, access to food depended upon your social group. And thus would show in poor weights, as well as the other determinant of, tribal health, as we saw, or was the access to healthcare, besides this thing. And one of the, I would then share some of the insights that we've had. And first one of them is, we realized, as even as public as physicians who were trying to provide comprehensive care, that people in small places, basically you read mean places and people in villages or in small cities, don't have small problems, technically small problems, and these problems require actually far more technical expertise. I felt far more challenged to be able to look at these problems in rural Chhattisgarh than I felt at AIIMS Delhi, managing those problems with less resources that one had, and more complex problems that people presented with. And the second observation that we've sort of made was that poor people get poor health systems. So therefore, there is a point in against making a program only for the tribals. I think that would be a regressive method to do it. One should do it in areas where there are more tribals, but it should be accessible to everyone. And having, focused and very exclusive programs for tribals would be a counterintuitive idea to get into healthcare. And the third sort of an observation, I'm going a little rapid because I'm told I have only 15 minutes to talk about, that we know that malaria will happen to some extent, and that snake bites will happen where there are snakes available. But snake bite deaths and malaria deaths, and I would talk about some other types of illness deaths, start where political power ends. And political power determines what type of health system that you get, and thus this fact is there. And let me illustrate it by an example for sickle cell disease that we've been discussing a little bit yesterday, I'm told. We know that the sickle cell disease parallels falciparum malaria because there is a protection that is provided to the people with that sickle cell trait. And it requires in this management certain drugs, infection care, which are seen in higher proportions, pain relief, and running health systems, well-functioning health systems. And it requires disability support that we know. And without care, we know that many Adivasi setups within Africa, as well as some of our own deprived Adivasi areas, the death rates could be almost 25% people dying by the age of 18. But if you realize it very clearly that the people who have sickle cell disease and are obese do far better than those who are Adivasis. So it is, to understand why a genetic illness should be performing poorly in one group, and it is basically the host who suffers the disease, and the factors that are, determine one's access to healthcare is what is guiding it. And that's why we must think about that. And yet, as a country, we have chosen to focus more on screening programs in fact, I would say to the relegating the care equitable care for sickle cell disease to a much lower, maybe not even second, but a third or a fourth rung level of care, which is, I think, it doesn't make sense at all. If I think, and it's in the ethics of any screening programs that you have to ensure that care to all those who have been found to be screened positive as disease. Our fourth learning was that, actually illnesses are biological embodiments of deprivation. They're not any sort of, it's not the gene or the pathogen that is determining it. It is actually the deprivation that a host suffers is determining it. And within this, we have realized that when one talks about illnesses that the poorer people in the country have, there is a knowledge heavy of the powerful who determine what research topics to be taken on. And this is something that I will question by saying, how do we understand about the pattern of disease in among Adivasis? I would illustrate with 3 examples. One is lean diabetes. We know that we have been told that we are a diabetes capital, but have we talked about the type of diabetes that the Adivasis or other people in central India suffer from? Even the idea that malaria is a seasonal illness and the seasonality is discussed as, being in the rainy season or immediate post rains is something that has to be questioned. And the third is about the entire pattern of heart diseases that we see in communities. And I would illustrate this by showing heart diseases, as even my ex-teacher, Professor Srinath Reddy would say, as well as we have accepted it as a nation, that ischemic and coronary heart disease is the commonest form of heart disease in more than 80% of people, and it is even added whether rural or urban. But with all and thus all the preventive strategies that we have proposed for in this nation of eating more, eating less, exercising more, and doing some and leaving tobacco, leaving smoking are made according to that. But when we observe as practitioners in Adivasi India, we realize that only 18% of of all consecutive cardiac problems are of ischemic origin, and 40% are rheumatic, and 42% are a diverse group of illnesses like cardiomyopathies, congenital heart diseases, and corpulmonales, which are also cardiac diseases, deserve a different level of care. And yet we keep on chasing this so-called paddled, myth that cardiac diseases in India are also among the poor and among Adivasis are also coronary, which is probably far from truth. And the sixth learning that we realized was that there is a lack of underpinning of equity in public health research also. For example, what do you choose for in the strategy? Should it be an energy or should it be equity or effectiveness and humanity? I think when the concepts which are vying for importance between equity, efficiency, cheap and affordability, or cost effectiveness in health, in policies or humanity, which should win first? Should it be that equity can be trumped by efficiency? I think it should not be the case. But often our policy makers would go for a very efficient system, which I think without ensuring equity, then there would be a problem. And where we realize primary level care is primary health care has to be provided at all levels of healthcare. It could be primary level, it could be secondary level, and even tertiary level of care. And it is not, it's not just primary health care is not just secondary, second-rate medicine for the have-nots or straight-jacket protocols and regimes. So, it is true that simple solutions are the best, but if optimal solutions are complex, so be it. You can't scale it up by dumbing down, programs that we realized. So, actually you have to decide on policies whether you're deciding for yourselves, and it is not for some amorphous community that you're talking about. So, let us talk about issues in research in tribal health. I think I would pose this. There are inequity in models and there are inequity in implementation. And because poor, as I said, poor people tend to get poor systems. Let me just take an example of snake bites and deaths due to it. Almost no new research has happened in the last 50 years. Whether it requires roads and vehicles and communication and skill sets of people who serve the tribal areas or supply chains, there is little work that is happening. Let's talk about, even when we talk about tuberculosis, and when the word MDR comes, we talk about multi-drug resistant tuberculosis as meaning both INH and rifampicin resistance is there. But what we observed in tribal areas that I have been working in, MDR tuberculosis is not the biggest problem, but my MDR is malnutrition first, then diabetes, and then retrovirus or HIV, in that order. Almost 88% people have undernutrition with BMI lower than 8.5. 9% might be having diabetes, and 1 to 2% would have HIV. And and when one talks about a provision of additional food for tuberculosis patients or for other illnesses that are due to hunger, then then our data had already shown in Chhattisgarh, which was published also in that even the the Chingalput study had failed us by providing that given the importance to food in tuberculosis. So why no supplementary food was being provided? We in Chhattisgarh could ensure food rations to be available for all tuberculosis patients, which was taken on by the national government, but was trivialized into a 500 rupee dole. And imagine all of us might even spend 500 rupees in a single meal over two people on a single evening, and we expected people with tuberculosis to be doing well on 500 rupees, which was further trivialized into giving someone taking a hold of someone's rations in a month. This Nikshay Poshan Yojana, or now increasing to 1,000 rupees. This does not make sense to me if one is worried about tuberculosis among the Adivasis. Because if you are even able to cure microbiologically, are you able to ensure people with Adivasis who have, not gained too much weight because of poor food intakes, how will they improve and return back to normal life? Now let's talk about a little bit about lean diabetes. This is a curious case. How do we study problems that happen among the poorest people and call them as Adivasis? Just as a case study, if I may suggest to you, this person, 35-year-old, whom I had been seeing for 10 years, lost 1 point body mass index from 17.5 to 16.5 in 2013, and he came with a cough of 1 month's duration. He was sputum positive and was then detected to have a blood sugar of 560 milligrams per deciliter. He was slow in responding, but he required metformin plus insulin for diabetes control even at the beginning of the treatment. Why did he have diabetes? Which was a faulty lifestyle he had led that was led to us to believe that diabetes is due to a faulty lifestyle. He did not take tobacco. There was no weight gain. He was working day of his life till he was unfit, and he did not have HIV. His oil intake was only 11 grams per day, and he was not consuming fruits. So my problem is that we have not, given importance to. So we saw among all and we see about 1,500 patients with diabetes new patients every year, and 70% of them have BMI which is either normal or less than normal, less than 18.5. And we don't want to talk about it. The WHO or the government don't want to recognize this entity called lean diabetes, besides the type 1 and type 2 that we hear about, which is a problem that we need to sort of take on. And I would urge the academics among us to sort of take this on, including AIIMS Nagpur, to take this on. So, and 50% of these lean diabetes require insulin within the first 2 years of treatment, which is not the case with type 2 diabetes. They're not ketosis sensitive. And blood sugars are very high, usually. Median age is 10 years younger than usual type 2 diabetes. And this is difficult to classify. This is not FCPD. This is not a type 1 or type 2 and a MODI. And what do you want to advise for these people? More exercises, do yoga, or eat less. I don't think any of these three advices would work in this case. So why can't we look at how poor people live and die? Is there a political will for this? Yes and no. I would say using an example of maternal and child health in this case, reproductive child health. We in Chhattisgarh disallowed sterilization among women who were belonging to the PVTG groups on the specious ground that their numbers were dwindling. That they may have had high fertility, but their mortality rates were also high. So they said the solution that the government of Chhattisgarh suggested was that we will not allow anyone any contraception or any sterilization procedures. Let them have these so that some will survive. If this was a model of development that we wanted to suggest, this is so we had to go as doctors, to the High Court, and allowing. Instead of asking for comprehensive primary care, we wanted to suggest such a regressive government order. So we went to the High Court, and the High Court has ordered that yes, it should be allowed. Adivasi PVTG woman should be allowed to have her right to having sterilization process if she wanted it. And even so, I must say we won the case in the High Court in 2016. And 9 years later, also the government doctors in Chhattisgarh are reluctant to operate upon PVTG groups, even though there is a government order, a legal order allowing them to use it. And yet our women, Adivasi women and our PVTG groups continue to suffer if we don't look at it. So what I want, finally, by asking you, you should be asking the right questions. More than because they are more important than answering the questions, if I may say. What is the burden and pattern of diseases that tribals in India suffer from? We must, till date, we can't say what proportion of tuberculosis in this country are among Adivasis. We don't have this data because we are not, we have from sample surveys, but we don't have, inbuilt in our data systems. What is the healthcare package that there should be at each level of health facility in tribal areas? Like, should there be an ECG machine at every PHC which in an Adivasi area is something that we don't know. Why don't we have price control over essential drugs? Should tertiary care be also supported for tribal areas or tribals? how should we handle NCTs among tribals? What is the best way forward for human resources and health in tribal areas? And to get back equity in center stage is my last plea for all. I would avoid by saying that, why do tribals have so many premature and avoidable deaths is a more important question than to just do verbal autopsies of all the things. We must understand biomedical causes, but we also should have a second bit of socio-political economic causes of deaths and not just limiting ourselves to biological causes of death. And in NCDs, I would suggest whether sickle cell disease, diabetes, lean diabetes particularly, rheumatoid arthritis, and rheumatic heart disease, can they be integrated care for these problems that we should be talking about? And how can we communitize care? Sharing out of hospitals and hegemony of the physicians can be questioned is something that we would go. I would finally say we must also look at community mental health. How do you diagnose severe mental health disorders correctly in tribal communities, especially those who are not unable to come to a hospital? Can this be done at home level? How can we ensure good compliance with treatment among those serious mental disorders where travel to city hospitals is not easy? And how do you provide help and counseling services for rural folk who attempt suicide and are at risk for a repeat attempt? So I would finally end by saying, more than our abilities as, tribal health providers, it is our choices that we make which make the decision. Thank you for your attention.
Thank you, sir, for sharing your value rights through your strategically explained presentation on the topic. I would now request our chairperson, Dr. Mrunal Phatak, to felicitate speakers. I would also invite Dr. Sanjay Zorpe, sir, to please come up on the stage along with Dr. Yogesh Jain, sir. Ma'am, please do the honors. Thank you, sir. To felicitate our esteemed chairperson, I would request Dr. Dilip Gore, sir, ex-chair professor, MUHS, Nagpur, to please felicitate our chairperson, Dr. Mrunal Phatak. Thank you so much, sir. I thank our chairpersons for their valuable time and their insights sharing on the session. Very soon, we'll be joined by the Honorable Minister of Road Transport and Highways of India, Shri Nitinji Gadkari. To let you all know, Shri Nitinji Gadkari is the mastermind behind our nation's highway empire. He has been an unstoppable force of innovation in transport across the nation. Nonetheless, he has been a trailblazer of the transformation in India, the visionary architect of our highways. So soon, Sir will be joining us, and he'll be present here to convey his best wishes and blessings for the FIST 2025. I would request everyone to please be seated switch off their mobile phones, avoid the front entry and exit gates. Till then, can I have the QR code, please? It's my ardent request to all the participants sitting here to please share your feedback by scanning the QR code. Also, I would like to mention there is a beautiful tribal village beside the auditorium, which has a display of beautiful, unique art pieces prepared and showcased by the tribal community themselves. So, in order to give them the honor, we all should visit the tribal village once. Shri Nitinji Gadkari soon will be joining us. Sir has arrived in the campus. Post lunch, we shall be conducting an exemplary panel discussion. So I would request all the delegates to kindly be present after lunch on time. To let you all know about the prestigious MUHS, that is Maharashtra University of Health Sciences, Nashik. MUHS has played a pivotal role in connecting the researchers across the globe, many of whom have Indian origin. MUHS, founded in 1998 in Nashik, Maharashtra, India, as a preeminent institution in health education and research. It champions the integration of health education, policy innovation, and public health initiatives to bridge the disparities and catalyze impactful, sustainable advancements in community health. MUHS is deeply committed to serving marginalized population through transformative approaches and strategic collaborations. With a network of affiliated colleges and cutting-edge programs, MUHS fosters a culture of innovation, empowering future healthcare leaders. The university's emphasis on interdisciplinary learning and research has positioned it as a trailblazer in addressing regional and global health challenges. And this symposium is a testament of these facts. Hats off to MUHS for organizing such a wonderful, stupendous, one of its kind international symposium.
Hello. Hello.
We are also privileged to witness this momentous conference at the prestigious institute, All India Institute of Medical Sciences, Nagpur. Nagpur is considered to be the center of India in the state Maharashtra. AIIMS Nagpur, established in 2018, has rapidly ascended as a beacon of excellence in medical education, clinical care, and health innovation. This distinguished institution is strategically positioned to address the diverse health challenges of the nation. AIIMS Nagpur embodies a commitment to equity and inclusivity, focusing particularly on undeserved and marginalized communities. This grand venue not only reflects the excellence and commitment of the institution, but also serves as a symbol of the cutting edge healthcare and research that AIIMS Nagpur stands for. Within few minutes, we all shall be having our Honorable Minister for Road Transport and Highways, Shri Nitinji Gadkari. I know all are waiting to witness this moment, the memorable moment that will be created. Sir will be showering his wishes and blessings, and he has come specially for all of us here, all the way out of his schedule. Sir has taken his time out just for all of us. Not only Nagpur, but the entire nation has seen a drastic transformation in last couple of years due to just the trailblazer, mind master behind the empire, the visionary architect of our highways. I would request
Ladies and gentlemen, please join in welcoming Shri Nitinji Gadkari, our esteemed guest today. I request Vice Chancellor MHS Lieutenant General Madhuri Kanitkar and Executive Director AIIMS Nagpur along with Organizing Secretary of FIST to please escort Shri Gadkari on the stage. Ladies and gentlemen, Shri Nitinji Gadkari is the Minister of Road Transport and Highways in Government of India and is fondly known as Expressway of India for his exemplary work. May I now request Vice Chancellor MUHS Lieutenant General Madhuri Kanitkar and Executive Director AIIMS Nagpur Dr. Prashant Joshi along with Organizing Secretary Dr. Sanjeev Chaudhary to please welcome Nitinji Gadkari on the stage. Thank you, sir. May I now request Honorable Shri Gadkari ji to address the august audience.
All respectable dignitaries on the dais, dear friends. First of all, it is to be a great pleasure for me that today the Maharashtra University of Health Sciences organizing this event in AIIMS related with the tribal community. In Indian situation, our socio-economic problem in tribal area are very crucial. Regarding education and health services, also there are a lot of problems, and that is the reason the socially, economic, educationally backward area in the tribal area is a big problem for the society. In our growth, GDP growth, it is 52 to 56% from the service sector and 22 to 24% from the manufacturing sector. Particularly from the agriculture and tribal area, our contribution in the GDP is only 12 to 13%. In the tribal area, maximum districts are backward. And today, government has decided to give highest priority for the development of tribal area. We just identify 500 blocks for that, which are socially, economically, and educationally backward. The important problem related with the tribal area is the tribal area is already maximum covered by forest. And that is the reason that they can't get good roads, irrigation facility, and there are a lot of difficulties about the development. From 95 minister, I had opportunity to construct a lot of roads in Gadchiroli and Melghat and tribal area of Maharashtra. But the problem was that everywhere forest department stopped the work. At that time in 2000, 1998, 97 somewhere, there was a big issue, and that was the issue of malnutrition and related with 2,500 deaths. The basic reason was there was no road. When our minister, chief minister, has taken the cognizance of it, and after finding, the committee has reported that there is only one problem because of that all the problems the people are facing, that is road problem. So I decided to go into the Melghat area, but my car was difficult to take it, my car on the road. So the merchant, one of the superintending engineer, now he's in Achalpur, with him, I just on his motorcycle, I got upon to visit lot of villages where no road was there. So after that, I decided to construct the road. It was stopped everywhere. The divisional commissioner of Amravati at that time, Mr. Kulkarni, was there. He was helpless. There was a lot of meeting with the chief secretary, chief ministers, but actually no result was there. So finally, I requested my chief minister, Mr. Manoj Joshi ji, that you leave it this job to me. I will see that how it can be done. I am really sorry. In forest definition, I violate the law. I make 200 roads to all the villages in that area. There was a high court case, and I written on the file in the future if there is any problem about it, it will not be responsibility of the secretary, chief engineer, or AC executive engineer. It will be only responsibility as a minister. I am ready to take that. We need integrated development, and we need to create employment potential in the tribal area. But the problem is that I understand that the ethics, economy, ecology, and environment is equally important. But we need to think on the line about the poor people who are socially, economically, educationally backward. I have a lot of experience about it because from last 25 years, we are running 1600 Ekal Vidyalaya in the tribal area of Maharashtra. We have 1800 teachers. Every year we have a workshop. But now this is the really a very important development which we need to understand and make the research of it. That Gadchiroli district in Surjagad, we have good quality of iron ore. And we have taken a decision and decided to start that mine. The area is supposed to be, once upon a time, it was the capital of Naxalwadi movement. And now the situation is changed. The 500 people from the Naxalwadi people, they surrender, they got the employment. And because of the iron ore, the processing plants are started. The 10,000 people are already getting employment. And that is, the Naxalism is not only a socio-economic problem, there are a lot of issues related with it. But because of creating employment, today the atmosphere is changed. Now they are going to start engineering college, polytechnic college, ITI, driving training schools. And now they have a good factory where they are making ready-made garments. The ladies are doing, and they got the big order from South Africa. So the process of socio-economic transformation is rapidly going on. At the same time, we construct all the road. I always taking head on this forest people. I also in favor of ecology and environment. Just near to your this aims, we have like an oxygen bird park. It is one of the beautiful park of world standard here, just 15-minute distance from here. So I'm also, my car is on biofuel. As a transport minister, I can constantly pursuing for biofuels, alternative fuel, electricity, ethanol, methanol, biodiesel, LNG, CNG. But at the same time, we need to understand the grassroots problem of the poor people. And we need to develop good technology. In the tribal village, there are a lot of arts, there are rich heritage. Everything is good. But one thing is very absolute that no philosophy can be taught to empty stomach. Where we need to have the good technology, on the basis of that we can develop the tribal area, Jal, Jameen, Jungle and Janwar. So there are a lot of technologies are available. From last 2004, I am working on a mission mode about diversification of agriculture towards energy and power sector. Particularly in tribal area, we have got Ratanjot, Moha, Sal, Karanj and Toli, that is non-edible oilseed. We are successfully making diesel from that. And now from rice straw, popularly known as Parali, we are making a 1 lakh liter of ethanol, then 150 ton of biovitamin, and 78,000 ton per year bio aviation fuel. So now lot of forest byproducts and the waste material we can use for making fuels. Also, we can make alternative fuel, we can make aviation fuel. I am not only talking only to giving speech to you. I have a practical experience about it. My turnover in my social project is now 2,500 crores. So I am on the base. My car is Innova, which is on 100% on bioethanol. So just from Nagpur, near to Nagpur Jabalpur road, we have constructed 1 kilometer of road under the guideline and guidance of Central Research Road Organization, and where in the from the rice straw we are getting bio CNG, and from bio CNG the byproduct is lignin, and that 35% lignin adding into bitumen and use rubber tire. Their powder is also 15% adding. The cost of the bitumen we can reduce by 15%. Our requirement is of 90 lakh ton of bitumen, out of which only 45 lakh ton capacity is in India. Otherwise, we have to import it. But today, now 400 already projects are in the process, out of which 60 already started, and by which we can get the lignin. And in my own ministry, we are taking 40% of bitumen is our requirement. So now it is to be easy for using the technology in the tribal area by conversion of biomass to bitumen and aviation fuel. It is to be a really a great thing for the development of that area. So we need good technology. I always telling to people two important philosophies. One is knowledge to wealth, and the second is waste to wealth. The innovation, entrepreneurship, science, technology, research, skill, and successful practices, we name it as knowledge, and conversion of knowledge into wealth is the future. And the second important thing is that is conversion of waste into wealth. In our corporation in Nagpur, we are selling our toilet water to the government of Maharashtra, Koradi and Khaparkheda power project, where we are getting 300 crore rupees per year as a royalty. And now the project is in the process where we'll get from the segregated municipal waste, solid waste, we will get bio CNG, and already 28 ton of bio CNG capacity is there, and within 3 months we will get that. And I just launched the motorcycle of Bajaj in Pune 3 months before. The 1 kilometer of petrol motorcycle, the cost is 2 rupees 25 paisa, and 1 kilometer for CNG, bio CNG, it comes to 1 rupees. So it is cost saving. So the ethanol, methanol, biodiesel, bio LNG, electric and hydrogen is the future. I am also working on the project in Gadchiroli, how to make hydrogen, where the university, the institution, the tribal department, they should think about it. There are a lot of schemes of government पट्टी फॉर द ट्राइबल एरिया साइकिल देता है तो कोंबड़िया देता है सब बेकार है वो पैसे खा के नेता लोग सब खत्म करें नो यूज ऑफ इट ट्राइबल सेक्रेटरी है कोई स्कीम अच्छी लाओ ऐसी स्कीम लाओ कि जो नॉलेज के साथ ट्राइबल युवाओं को कुछ करने का उनको मौका मिलेगा ये आश्रम शाला वसति गृह मैं बोल सकता हूँ क्योंकि मैं बाकी तुम्हारी तो ताकत नहीं बोलने की इनके सामने इतनी गंदी स्थिति है ना फूड की क्वालिटी अच्छी है अब ज्यादा बोलता नहीं आगे की बोलना मेरे लिए उचित नहीं है ये सब स्कीम को रीथिंक करो skilled is important in the Orissa there is a skilled universities there and skilled is very important where we can create more employment potential to Gadchuli district the steel industry is very important and already I declared that within 5 years the Gadchuli will be the #1 district of Maharashtra giving maximum GST to the government because of the steel industry. We have 80 kilometer of crash barrier of bamboo. Just from here, Baroda to Vani, we have successfully implemented. And now we have taken decision to out of crash barrier, 10% it should be compulsory on bamboo. The Bhima bamboo from Karnataka, having the productivity of 150 ton to 200 ton after 2 years per year. And now we can make cloth from bamboo. We can achar, we can make furniture, and the most important thing, we can make ethanol. In Numaligarh in Assam, a big project is there where we are making bioethanol from bamboo and giving petrol and diesel to Bangladesh. So I just suggest the refinery MD that in your pipeline you make this ethanol from bamboo, add 20% in petrol sent to Bangladesh. Their cost of the petrol will be reduced by 2 rupees and the people will get the employment. Today I feel that regarding the new innovation and new research, we need to develop new policies. And regarding the health sector also, the problems are not very recently we resolve that. You are not responsible. We are MLA MPs are responsible. When anyone transferred to Gadchiroli, our MLAs MPs are ready to give the service to the people who transfer to Gadchiroli. Immediately they asking minister, please give the stay. So there is a problem about the people, about the officers, about the doctors. No doctor want to go to Gadchiroli. They take it as a punishment transfer. And it is really a big problem. In the world today, the whole world is discussing about the Happy Human Index, Domestic Happy Human Index. And that is related with the education facilities, health facilities, employment. And most important thing is regarding health services, now the technology is there by which we can give the services to the poor people by starting telematic by way they can give the medicine. Even in Gadchiroli, with the satellite, they can be approached to the doctors in the AIMS, and AIMS doctors can give certificate and giving whatever the medicine they need, they can sign it and they can take it to them. That is to be the great service. We need to find out some solutions for that. And it is only possible with the social consciousness and social responsibility and social sensitiveness. If there is a strong political will for doing something for the poor people, then we can do it. And that is exactly we need the good services to the tribal people. I am really happy and giving my thanks to the organizers, the madam, Dr. Chaudhary, director of AIMS, and all of you, that you are thinking somewhere about the downtrodden people of the society, those who are socially, economically, educationally backward. It is really a great thing if with your reports, if you are going to improve the health services in the tribal area, it can be a great thing. Because from last 25 to 30 years, I am working in lot of charitable projects in the tribal area. So I understand what type of problem they are facing. And I am really happy that your initiative, your approach, and giving support to the tribal community is going to inspire a lot of new doctors, the new generation, to do something for the poor people. We are always telling people that chalo jalaye deep wahan jahan abhi bhi andhera hai. The people who are socially, economically, educationally backward, where we need to do something for them. We need to make government schemes very, very proactive, transparent, time bound, and result oriented. I always have the opinion that the financial audit is very important, but performance audit is more important than financial audit. So exactly on that line, particularly in Vidarbha area, we have the Amravati district, then Gadchiroli, Chandrapur, where a lot of tribal communities there. I got opportunity to visit many villages in tribal area because in every election, lot of people are waiting for me in the tribal area. Actually, the time when there was Naxalite movement was very strong. The police was very disturbed. Why, sir, you are coming here? But I visited all the area there, and I'm really have a emotional and sensitive touch with the development of that community. And I feel that this is the appropriate time that we have to take the proper initiative for that, and that is going to change the socio-economic transformation of that area. Regarding the health services, there are a lot of new schemes from the government of India and state government. The implementation is very important. And that is the reason that if you can implement it in a way, it can be very much helpful for the poor people. I am really happy that this conference is very important, which is going to decide the new futuristic program for that area regarding the health services. Your suggestions, your new initiative is going to helpful for the people, and by which we can make them really a sustainable life, which is very important. I feel that this your initiative will be helpful for that. I am giving my special thanks to our medical university vice chancellor. Sanjeev Chaudhary is really doing good job. Generally, I don't have very good opinion about doctors. But Sanju is such a good doctor who is always helping without any expectation to the poor people of the society. And there is a huge response for him. This type of doctor we need. I understand that no philosophy can be taught to empty stomach. To make money is not a crime. But at the same time, we should think about the people who are socially, economically, educationally backward. The people who don't have to pay, don't have any capacity to pay, where we need to think something positive about it. When the people who are giving you good fees, you can take it, no problem. But at least when the poor people are coming to you, try to help them. I always have a good geet in my room. Manasa satatam smaraniyam, vachasa satatam vadaniyam, lokahitam mama karaniyam. And I always telling to my community people, the politicians, that the politics is an instrument of socio-economic reform. So why I'm politically strong? Because I'm doing social work. My social work is a strength for my politics. And that always I try to convince my colleague that you should do social work. The positive social work in the sector of education, health services, development, employment, it is to be most important thing by which we can change the socio-economic scenario of that area. And ultimately, when you are doing good job, people are always supporting you. I'm really happy that with this initiative, it is going to change the picture in the tribal area of Vidarbha, at least in Maharashtra, and people who are coming from abroad. Their guidance is also equally important. Sickle cell, thalassemia, big problem is there. I am constantly pursuing with Dr. Doshi from many years to start bone marrow. I am the person responsible for this AIMS hospital in the city, but I am not satisfied because when this hospital is not going to help the poor people of this area, then what is the use of hospital? So there we need to find out exactly what are the problems, health problems in that area of the poor community. And and where you need to have the program for that. And that is the need of the hour, that is the need of the society. Once again, I'm giving my thanks to all of you and best luck who are coming from abroad here to participate in this conference. Also, their experience, guidance will be also useful. Once again, best luck to all of you. Thank you very much. Namaskar.
Thank you, sir, for your practical guidance and words of wisdom. Most importantly, giving us time from your busy schedule. Your presence has elevated the spirit of the conference. I request the audience to please give him a standing ovation. Thank you very much, sir.
और फर्स्ट इज हूँ Soon we shall be coming up with the next scientific session in the line. I request everyone to keep their phones either on silent mode or switch it off. Those who have not yet given the feedback through the QR code, I would once again request the team to display the QR code on the screen. It's my request, a personal request to all the participants to kindly scan the QR code and give a feedback. Thank you. For the next upcoming session on the theme, Technology and Innovations, Navigating Transition in Tribal Healthcare, I would like to invite the chairpersons, Dr. Rasika Gadkari, Professor and Head, Department of Pathology, AIIMS Nagpur, and Shri Vijay B. Wagmare, IAS, Secretary, Tribal Development Department, Government of Maharashtra. I would kindly request the chairpersons, Shri Vijay B. Wagmare, IAS, Secretary, Tribal Development Department, Government of Maharashtra. Welcome, sir. Please help me welcome with a big round of applause to our chairperson. Can we have Dr. Rasika Gadkari? Okay, due to some emergency, she has to leave. So you would do the honors. So the first speaker for this scientific session, I would like to invite Dr. Indu Bhushan, former CEO, Ayushman Bharat, India. Please help me welcome Dr. Indu Bhushan. He will be speaking on the topic from margins to mainstream, advancing tribal health with technology and innovations. All over to you, sir.
So, good afternoon, everyone. It's really a big challenge to speak after charismatic speaker and just before lunch. So I'm on both sides a little bit under pressure. But I want to start by thanking Professor Kanitkar Professor Joshi, and most importantly, Professor Chaudhary for organizing this wonderful and conference for sharing information, knowledge, and research on tribal health. And I have, in my career, seen first of this kind, and so I am really very grateful to them for doing this. I'm also grateful for them to invite me to this conference, even though I'm not an expert on tribal health. I really appreciate joining this, understanding more about tribal health, and improving my knowledge base. Although I've not worked on tribal health, I've been fortunate to work on two very transformative flagship schemes in the country. And both of these schemes have been, both of these schemes have had impact on the most vulnerable nations in the country, including tribal health. I'm also very happy to share with you that one person who's worked with me on these two schemes is here, uh, Dr. Praveen Gedam, who is now Commissioner of Divisional Commissioner of Nasik. I was very privileged to be working with him. And so with that, I would like to start my presentation with something I learned from my daughter. My daughter Devika Bhushan, she went to Harvard University for medical. She studied in Harvard Medical School. And before she joined the school, she was asked to read this book. She was asked that you should read this book and come. The book was called The Spirit Catches You and You Fall Down. This book is a true story. It's a very deeply moving story. I have also read it on her recommendation. And it's about a young Hmong girl. Hmong is a tribe in Laos. And that girl with the family had moved to Laos, from Laos to US. And she had epilepsy. And this disease actually became the fault line between two vastly different worldviews. One was shaped by the traditional knowledge and values of the family, and the other was shaped by the science of the modern medicine. And both these views were not incorrect. Both did not lack any intelligence. They did not lack any dedication or compassion. Yet, despite their best intention, the doctors and this young girl, her name was Leah Lee, the family struggled to truly hear and understand each other. And this led to disastrous results. And this little girl truly died. And this, if you read this story, then you'll understand that the story is not about just one child or one community. It's about universal challenge of bridging cultures, disciplines, and belief systems in the healthcare. Now, you would ask that why did the Harvard Medical School ask my daughter Devika to read this book before coming? And my own sense was that they wanted Devika to understand the limitation of modern medicine. They wanted her to come to the school with some realism, some humility. And of course, they wanted her to understand that healing is not barely about knowledge, it is about understanding. And understanding is a two-way process. Every encounter between a provider and a patient, between a system and a community, is an opportunity not just to meet, but to learn, listen, and to respect. And if we can recognize that both sides are teachers as well as trainers, we will move closer to a healthcare system that is not only effective but also humane. This book also has a very nice quote which I've put on the right. It says that I have always felt that the action most worth watching is not at the center of things, but where edges meet. Of course, like any philosophical quote, it can be interpreted in different ways. But my own simple interpretation is that it's quite easy to work at the center. It is quite easy to work in mainstream. But uh, when you want to use your talent truly, you need to work at the margin. That's where a challenge is, and that's where you can make the most difference. And that's what my topic for today is, from margins to mainstream. So let me just quickly go through what the problem is. And this problem has been discussed and shared by many of us here. And Professor Kanitkar presented this information yesterday and today also. So I'll just run through it quickly. Starting with these are the numbers from the latest comprehensive annual modular survey, which is done every year. It's about 2 years old, and it shows the the relative position of tribal population in terms of per capita monthly expenditure. And it is shown by the red dot for all states. And you can see that for most states, almost all states, they are at the bottom. They are worse than scheduled caste. They are worse than other backward caste, and they are way worse. The difference between tribal population, consumption, and other population is vast, and that actually reflects into their poor health status. We have seen the numbers from yesterday in terms of high level of stunting, wasting, women having anemia. Also, we've seen from yesterday that other problem that they have is that there's a limited healthcare infrastructure. Only 21% of tribal habitations have primary health care, which is within 1 kilometer. There's almost no access to tertiary care. And that also leads to poor healthcare seeking behavior. We see that only 22% of tribal population goes for outpatient care, only 11% for inpatient care. And as was discussed, that a lot of proximate determinant of health, including social determinants, are adverse. We have spoken since morning and yesterday about high tobacco and alcohol consumption and poor access to safe water and sanitation. So if we summarize, there could be 5 different buckets in which we can see why the poor health outcomes are there. There's a geographical barrier, there's a barrier, infrastructure gap, economic barriers, and poor access to water and sanitation. Now, the question is that what are we going to do about it? And here I come to the 2 schemes where I've been fortunate enough to work. First scheme is the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. It was implemented by Honorable Prime Minister in 2018. It was launched in 2018, Jharkhand, Ranchi. And it had, at that time, two main legs. One was Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, which provided support of 5 lakh annual coverage for 10 crore poor people. And it included all 100% tribal population. The idea was that in socio-economic caste census, all families which are tribal should be included. And other leg was health and wellness centers, which are now called Ayushman Bharat Arogya Mandirs. And now we have more than 1.5 lakh, about close to 1.7 lakh centers, which are providing preventive, promotive, and curative health. And each center covers about 500 people. Also, together with this, scheme was launched for free diagnostics and providing medicines. And all 3 together were supposed to reduce out-of-pocket expenditure, increase access to health services and reduce or eliminate catastrophic health expenditure. And I'm very happy to report, and I'm very proud to report that the scheme, even though it's only 6 years old, has done really well. Today, uh, every month, we are providing more than 20 lakh free treatment under this scheme. And so that you can see millions of families are, we are saving them from impoverishment and catastrophic health expenditure. And if we look at particularly the tribal population, we also see a very good impact. 77% of tribal households are covered, although it should be 100%, but 77% is not a big number. If you go back to 2018, the number was less than 15%. So in 5-6 years time, the coverage has increased from about 15% to 77%, and hopefully the entire tribal population will be covered. We also see that there is an increased utilization of services. Although Pradhan Mantri Jan Arogya Yojana was for inpatient care, the survey which was done about 2 years ago shows that there's been increased both use of outpatient and inpatient and significant use. And I've done a paper which is going to be coming out in Lancet shortly that also shows that there is a significant reduction in out-of-pocket expenditure as well. So within 6 years' time, we see that this scheme has reduced the financial barrier for use of health services, increase the use of services, and reduce the expenditure that households are making on use of services. Second scheme that I worked on together with the Praveen Gedam was at that time it was called National Digital Health Mission. Now it's called Ayushman Bharat Digital Mission, and it provided the backbone. It started providing the backbone for digital health in the whole country, giving digital IDs for everyone, digitizing health records, creating standards for digital health records, and also providing IDs for doctors and hospitals. And once that scheme is fully operational, fully deep-rooted, it should have the same impact on the health sector which UPI has had in the financial sector. So in terms of ease of doing services, in terms of ease of sharing of information and analysis, it will have the same impact. Now your question will be that how does that link to tribal health? And I would say that if the scheme runs well and it matures soon, and which it will in times to come, it will have a transformative impact in terms of tribal health. One thing that I can share with you is that, for example, it will improve the portability. As you know that a large number of services are provided to tribal population by different departments, whether it's Women and Child Development Department or any other. So you have services being provided. If you have one ID and your all records are electronic and digitized, all of them can be combined together. And right now, all this information is scattered all over and can't be used together. Once you have one ID and all the records are digital and they can be linked together, therefore the portability of all those records will be important. When you go to a doctor, it will be a better diagnosis because the doctor will have more information about what kind of treatments you already have had, what kind of contraindication to medicines you have, and so on. So it will lead to better diagnosis and better treatment. It will also lead to more accountability of doctors and system because we'll have record of what has been given, what kind of diagnostics was done and what kind of treatment was done. Was there a link between diagnostics and treatment? That could be ascertained much better, more effectively with the electronic records, right? Also, I think a speaker is talking after me about AI solutions.
Many of the AI solutions can help in terms of more effective screening, diagnosis, and ensuring individualized treatment. And we can increase the access to services through telemedicine using digital health. And again, already Sanjeevni has done more than 50 lakh consultations, and that can actually improve much more. I think, in my view, that revolution has only started. Not only this, digital health will help in terms of better monitoring and research, and it will improve program management. Right now, program management, which is based on paper record, is not that effective. Even Ayushman Bharat PMJ, because of all the digital platform, we were monitoring it through digital means, and that was the only way it could have been done. It would also, in terms of help in terms of identifying hotspots where the problems are, and we can have more quicker, more effective response in place. And even more important would be research and innovation, because there'll be more data which would come out, which will be available to researchers, and it would help in terms of identifying the problems that tribal population have, and what kind of approaches work. And digital health, if done well, could also help in terms of identifying more culturally appropriate and culturally tailored health care solutions. So if I summarize this, the two schemes together, Ayush Bharat PMJ and Ayush Bharat Digital Mission, Digital Health, have provided financial protection, have improved access to services by reducing costs, but also through digital means, through, for example, for telehealth. It also has helped in terms of data-driven insights and community engagement. Also, it is going to be helping us with the culturally appropriate solutions. But I have to go back to the quote that I started with before I finish, which was that the action most worth watching is not at the center of things, but where the edges meet. And just to remind you that the true transformation does not happen at the comfortable center, but at the edges, where the different world meet, where traditions meet the technology, where modern healthcare meets indigenous wisdom, and where the marginalized population interact with the mainstream population. So journey to improving tribal health is not just about delivering services or expanding infrastructure. It is about bridging divides. It is about filling the gap, respecting indigenous wisdom, and designing solutions that are both scientifically sound and culturally rooted. With the help of all these innovations that we've put in place, digital health or inclusive governance, we have now tools to bring healthcare to the doorstep of every tribal household. We can empower them with knowledge, and we can ensure, as Precious mentioned this morning, that no one is left behind. Yet, technology alone is not enough. Real change would require trust. It demands a shift of mindset, one that sees tribal communities not just as a beneficiary of healthcare, but as active participants and partners in shaping their own well-being, as was mentioned by Dr. Jain earlier. So from margin to the mainstream, this is our collective responsibility and our greatest opportunity to create lasting impact. And I thank you for your attention, and thank you for opportunity to speak to you.
Thank you so much, sir, for wonderful insights. And your efforts have really tried to meet the edges, sir, as you said, as you started with the quote. Thank you. The next speaker I would like to call upon, Professor Dr. Ala Azmi Ahmed, Adjunct Professor, Pediatric Orthopedic, Palestine, Polytechnic University, Palestine and Medical University of South Carolina, USA. Welcome, sir.
Thank you very much for having me, and I'm honored to be part of this prestigious Congress. And it's not the first time for come to India. Maybe it's the 11th time coming to India. I have a lot with India, and I'm not surprised by the warm welcome that I'm having from India. But to be honest, India has an impact on my work in three ways. I invented a technique for surgical management of what we call it early onset scoliosis. That is scoliosis, spine deformity in children below 10 years of age. And I've done it in Palestine since 2008 on rarely, but from 2013, I've been doing it regularly. The thing is that when you do something innovative, and it's coming from Palestine, people will be skeptic. And you want it to be globally accepted. The first institute that was concerned, and they did it, and it made a huge step to become globally, was AIMS Delhi. And AIMS Delhi have done this technique since 2018, and it gave a huge credibility to this technique, to what I call it the APC technique. The other issue is that in the University of Toledo in Ohio in USA, the biomedical engineering department, which is composed, all of them are Indians, and they loved the technique, and they had a PhD, actually thesis about the APC. And they have done virtual computational study that proved the efficiency of this technique. And this made a huge impact also, globalizing this technique. Now this technique is going all over the world and accepted fully. And the other thing is that since I'm a global surgeon, I'm interested in how to implement complex surgeries with the local doctors in rural areas. And this is happening with the straight spine program that we do every year in Calcutta, in India, in a rural hospital. And it had huge success in implementing scoliosis services in rural hospitals. So thank you, India, for giving me the chance to globalize the technique that I have done and to improve and share ideas with people all over the world. Now, I'll come to the thing that is very important, which is, since I'm a global surgeon going to many countries implementing programs. And I learned one thing, which is the title of the work, is what I call it now, dignity-based care. Dignity-based care means empowering, and not empowering patients or poor people to have this service. No, it's empowering local health workers to do the process and to be part of the process and leading the process that will give access to the local people to have this service. And empowering them is not by money, empowering them is by knowledge. And this is the main idea of the relationship, the missions, and also going to rural areas, and also for the tribal activities. So what is traditional medicine? Is according to World Health Organization, defines traditional medicine as a form based of knowledge and practice of indigenous beliefs and ancestor skills experienced from different cultures. But what about the problems related to traditional medicine? Not much knowledge of the strengths of their remedies. Dosing depend entirely on each practitioner. Lack of standardization. Everyone do whatever he or she wants. And lack of, this is very important, of proper documentation and knowledge. What are our objectives? Is to heal, serve, and empower the tribal community by including the traditional health workers in the system, promote and respect the well-being of individuals by offering quality holistic healthcare, create and build trust. As our previous speaker, he was talking about the trust, which is very important, and recognize the power of our past, producing resiliency and self-determination. Now, the issue is that how can we get the ancient wisdom enhanced by modern technology? This integration is hugely important, which will deepen our understanding of traditional practice and paves the way to innovative treatment and therapies. This integration will offer a unique chance to preserve indigenous heritage. The only way to preserve the heritage of the indigenous people in the indigenous practice is to get the data, and to get the data with a clear object of healthcare standards. So the database established of comprehensive traditional medicine database significantly improve the efficiency and accuracy of traditional medicine research, enabling easier access to information of ingredients and encouraging interdisciplinary collaboration. And I'll give you just an example afterwards. It's for objectification, standardization, and quantitation in research. So how can we do that? Steps to implement data. It cannot be done without appropriate tools. And the importance is to develop user-friendly artificial intelligence tools. Without that, if you have complicated issue, it will not be accepted by the traditional health worker that can be integrated into the daily practice. This is hugely important. We need to think, how can we do that? And ethical considerations, of course. Increasing the use of patient data necessitates robust privacy protection and ethical guidelines. And the clinical records, as our colleague have said about the importance of the clinical records. The complexity arises from the diversity of the data. You know, everybody is having something, and there are traditional books that you need to get out, and the clinical observations. So how can you get the data to be appropriate data that will add and will give you the necessary step to have big data and to go for artificial intelligence? I'll give you an example here from the traditional Chinese practice. Here you can see data mining, and example for the herbs. You get the ingredients, of course, and you get all the details about who was treated by what, and with the ingredients you have artificial intelligence analysis because you have already huge data about that, and then you can apply it for the improving the practice of the people. This is for the herbal issue. And also there is virtual screening technology. You can use images, you can use text, and you can use many forms that will improve the data, that will accumulate and give you artificial intelligence tools. And that will facilitate the analysis of complex symptom patterns and recommend appropriate traditional medicine prescriptions and personalizing treatment strategies. Now, since I'm an orthopedic surgeon, I'll give you an example with the bone setters. What are the bone setters? The traditional bone setter is a practitioner of bone manipulation. And according to the view of the patrons and the community in large, he is the one or she is the one who is efficient to deal with broken bones. But sometimes you see in the literature that there are unqualified practitioners who takes up practice of healing without having any formal training. So either you exclude them or you put them part of the program, embrace them to strengthen your practice in dealing with fractures. So few of us are likely to practice without having a bone setter for arrival, but if we can cure a case which have failed by us in modern medicine, and fortunately it can be done with the practitioner, then we can engage them. And also, despite the technological advancement in modern medicine, bone setting have thrived as an alternative source. This is in the literature from Nigeria. And in the absence of orthodox healthcare provider, traditional healers in some cases provide 90% of the primary healthcare. And if we look at the statistics in the literature, 85% of Nigeria are having the first action when they have broken bones, they go to bone setters. In India, you have 70,000 bone setters. How can you exclude them? So we need to empower them. But there is a problem that within 10 years of that study, there is nearly quarter of the patients who were treated with the bone setters for broken bones have gangrene, ended with amputations. So how can we solve this problem? If we look at the reasons why people are going to bone setters, about 70% is because of quicker service, because they are part of the tribe, and cheaper service, 70%. Fear of amputation, combination of the above, and strike in a government hospital. And the reason for going to the modern medicine was mainly because of the complications, the non-union or malunion. So how can we go and upgrade the bone setters in a way that can be efficient in the management and be part of the practice? We need to understand how the bone setter sees the wound. First of all, you can see from 10, all of them take the history of the injury, observe the site of the fracture, measure the limb when where the part is injured, and flex and extend part of it so as to see how he or she can do, and touch and feel the fracture injury with the hands. All of them are doing the same issue when you go to a bone setter. And then only 30% of them use X-rays in evaluation of the fracture. All of pull and manipulate the fracture. More than half of them massage with warm herbals and things. And only 10% of them deal open fractures. Most of them are referred. And application of butter and herbs and doing application of a splint. All of them are doing that. And only half of them are doing some pain management and use of supportive device to exercise the limb. All of them are doing that. So if we understand how the traditional bone setter is doing the process of dealing with the patient. So, for example, if we give him access to the X-rays, it will be much better. If we give him or her some titles, some notes that they can look at before doing the massage for the fracture line, it would be good. Now we can see the experience in Nigeria, for example. In open fracture, they refer most of the patient, which is a good thing. And for the closed fracture, they reset the bone and put the splint. And it's usually for at least 51 days and for the splint. What about if we do something that we call trad orthopedic clinic, traditional orthopedic? So we merge the modern medicine with the traditional medicine and give a chance for the patient to have better service in the tribe. And here we can see, this is an experience that was done in Nigeria, that some of the bone setters have 2 days of a workshop giving them some standard of services, and the other group didn't have. And what we have seen, that the accepted union was nearly 50% in the people who had the 2 days workshop. It was less than 20% in the people who didn't have. The malunion was less, the non-union was half, the delayed union was less, and post-traumatic osteomyelitis is much less in the people, and the limb gangrene was 25% of the incidence that was done. So what you can do, you can embrace the traditional bone setters and get them part of the program And with that, you can have a clinical data. And with adding the clinical data more and more, you can have big data, and then you can engage it with artificial intelligence. So what's the take-home message? With the rapid advancement of artificial intelligence algorithm and increasing availability of high-quality, extensive database, the development of artificial intelligence in the field of traditional medicine would lead to more accurate diagnosis, better understanding of complex cerebral interactions, and the development of innovative treatment strategies using big data, that is data collected from traditional medicine doctor, is crucial. How can we do that? With the tools that is necessary for that, and with embracing them and putting them part of the program. Thank you very much.
Thank you so much, Professor, for the stupendous presentation and your display of your work on the tribal health. I would request our chairperson to kindly felicitate our speakers for the session. Yeah, I would request the chairperson to sum up the session.
Thank you very much. I think both the sessions by Dr. Indu Bhushan and Dr. Allah Azmi, I think you came all the way from USA, 11th time you said. Yeah. Both were very engaging. And if you can just relate it with what Honorable Gadkari ji said, because he's the one who set the tone. He spoke about the different aspects of the tribal life, about their health, about their education, about the infrastructure that is available, the cultural practices that they have, one part. And secondly, the challenges that we face when we want to give certain services to them, like even building, say, infrastructure, building small roads, and a lot of hurdles coming in the way. And I think that is where this technology part comes into picture. And Dr. Hindu and Dr. Lazmi both elaborated on that. Dr. Hindu, I really liked the way you summed up the entire thing, in the 5 blocks that you mentioned, and that includes what Dr. Lazmi also spoke. It was about, the financial expenditure that each tribal family has, per capita finance expenditure that they have. And that reflects the kind of status they have. The challenge in terms of the access that these tribal communities face from time to time, whether it is the normal times, when if you're talking about the rainy season, it becomes even more challenging because accessing those people in the rainy season is very difficult. Data that we can have, where you spoke about, having that data and getting into the AI, into some models that we can have, and about the community engagement, because that is the most important thing that again you emphasized on that, and the cultural sensitivity. When you spoke about the a very new term that I learned is the tradopathic services, right? Having the traditional services and the scientific services together so as to merge kind of both kind of approaches together, so that the acceptability towards the traditional way of doing things and the scientific way of doing things happens. So those are the aspects. I think I was also sitting here alone. I was forced to think, and I have been thinking about the technology, right from the days of just computers, when we had computers and we thought it's going to change everything, change entire humanity and benefit us. And then we had mobile technology, and then we also had telemedicine, and we thought यहाँ पे बैठे बैठे सब लोगों को हम treat कर देंगे. And then we had internet, and now we have so many applications. So since I am from the administration, just before coming here, I just asked my people to do some research, because the today's session is about technology, right? The tribal health and technology. So you will be amazed to see right now the number of working softwares that this government has in all is 51. We have 51 softwares working in one way or the other. Out of that, government of Maharashtra has 22, government of India has 21, and each of the field level worker is creating the kind of data that is needed for analysis, and that is again where I believe uh, where Dr. Allah Azmi spoke about having AI models made. So we have the kind of data, that is getting generated every day, and we need a kind of data analysis that can actually empower on that data and make some sense out of it, because humanly I don't think it is possible. So both of your sessions, I think they complemented each other, and they would really add to the way, the approaches that we would be having towards tribal health. I also take this opportunity for inviting me for chairing this session, because somewhere I think it also gives us a platform, a framework to think and do better. क्योंकि गडकरी जी ने कहा था वहां पे, and I have to refute that, some part of it, because as the secretary I have to put my side also. We have our schools, we have our health system that is working, and I think we need to work in a more holistic manner. We have different departments, and that is why I think this forum, this association, this conferences enable all of us to come together to think through, not just through a medical lens, because it's not just about medicine, but the cultural framework within which operates the technology that is available to us. So I really thank you for giving this platform and making me part of this gathering and the entire symposium. And thank you very much, Kanetkar Madam and Dr. Chaudhary, for having this wonderful session here. Thank you.
Thank you so much, Sri Vijayji Wagmare, IS officer. So though you were alone, but you caught the eyes of the entire audience of the hall. Thank you. I would request the chairperson to kindly felicitate our speakers. Dr. Indu Bhushan and Dr. Ala Ahmed. Thank you. Thank you, sir. To felicitate our esteemed chairperson, please help me welcome Dr. Amish from Tanzania. I would request Dr. Amish to felicitate our chairperson, Dr. Vijay Wagmare, IS. Thank you. I thank the chairperson and the speaker. Yes, sir. Group photograph. Sure, sir. I warmly thank the speakers and chairperson for the session. A very interesting lined up session we have after the lunch on the theme itself, which is very interesting, that interesting insights from tribal territories. The speakers are from all the way from Republic of Armenia, Dr. Naira and Dr. Lilia. So I would request immediately after the lunch to kindly assemble and give your ears to the wonderful talk that will be happening after the lunch. So all the audience is requested to have the lunch quickly and be placed in the auditorium. The lunch for the faculty is arranged on second floor auditorium and the lunch for the delegates in the Epicurean hall beside the auditorium. Thank you. We shall shortly see you after the lunch. Soon we shall be starting the sessions. So without delay, I would request the participants to please assemble in the hall after the lunch. Thank you. Okay. Okay. The lunch for the delegates is at the dining retreat, which is on the right side of on your right side of the auditorium. It's not the Epicurean, but it's the dining retreat. Venue is dining retreat, and for faculties, second floor auditorium. Thank you. पैनल चलेगा सर एक मतलब पैनल ही हमारा जैसे अभी लंच जो है 2 से 2:40 तक ये हो जाएगा सेशन पैनल विद इन एन आवर 60 मिनट्स तो शायद 4 बजे 4 है ना देन डन पैनल डिस्कशन स्टार्टिंग 4 बजे पैनल डिस्कशन कब तक चलेगा